Well, good morning, everyone. If I could ask you to take your seats, please, we'll get underway. Good to see and hear and feel plenty of energy in the room, because you're going to need it today. So welcome. So my name is Brenton Jones and I'll be your MC for today. I'm back again. I think this has been the fourth year in a row and it's been an absolute privilege. So, thank you. Checks in the mail. Good on you. So it is my pleasure, of course, to welcome you all to the 2026 annual immunisation update. And it's wonderful to see so many immunisation providers coming together, some very familiar faces plus new ones coming together in one place. The care and commitment you bring to immunisation every day plays a vital role in protecting the health and well-being of our communities. And we thank you for the important work you do and the real difference you make. Now, it's now my great privilege to welcome Uncle Neil to deliver our welcome to country. Uncle Neil is a highly respected Wiradjuri elder, whose cultural leadership and lifelong commitment to country and community spans more than 5 decades. A proud custodian of Wiradjuri language, stories and cultural heritage, Uncle Neil has dedicated his life to protecting sacred places, strengthening community connections and ensuring that culture is lived, spoken and shared for future generations. Uncle Neil, we welcome you.
Good morning, everybody. We've got a large audience today. Look, welcome and welcome. Gwambaradu Nuramangu. In Wiradjuri, that means welcome to country. For those who don't know me, my name is Neil Ingram Senior. I'm a proud senior Wiradjuri elder. I would like to thank Alison Sullivan for the kind invitation to perform Welcome to the Country today. Thank you, Alison. First of all, I'd like to show my respect and acknowledge the traditional owners of the land on which we stand, the Wiradjuri people, for their continual connection to the land, waters and community. I acknowledge our elders, past and present, for their cultural knowledge and wisdom, and I acknowledge the sorrow and pain suffered by members of the stolen generation. I too am a survivor. Wiradjuri country is known as the lands of the mountain plains and the 3 rivers. These rivers are the Womble, the Galari and the Murrumbidgee. These rivers are important to us and they are essential to the social and spiritual needs of the Wiradjuri people to sustain all parts of our sacred landscape. The 3 mountains form the songlines of my 3 brothers' story, and we need to protect our sacred songlines from any future destruction. These mountains are Walu, Mount Panorama, Gardabulla, Mount Canobblas, Gobblemundalinya, Mount Macquarie. Wiradjuri country is one of the largest nations in New South Wales. It begins west of the Great Dividing Range, and our southern boundary is the Milawa, or the Great Murray River near Albury. On behalf of the Wiradjuri people and in line with Wiradjuri culture protocols and practices, I welcome you to country. Welcome in language. Yunay Galamu, Gabi Bangbu, Burai Galamu, Gwambaradu Nigilgi, Wiradjuri Gu, Nuramangu. Welcome to Wiradjuri, welcome to country. Mandang Guru, thank you. I hope you enjoy the rest of your day. Thank you very much.
Thank you for that beautiful welcome, Uncle Neil. It is now my pleasure to welcome Katie Pryor, Executive Manager, Primary Health Care Integration and Reform from the Western New South Wales Primary Health Network, to deliver our opening address. So please make Katie welcome.
Hi everybody, it's lovely to see you all today. It's always a privilege to have Uncle Neil welcome us, so thank you very much to Uncle Neil. I would also like to acknowledge the Wiradjuri people as the traditional owners of the land on which we're meeting today. Also pay my respects to elders past, present and emerging, and to all Aboriginal people here today. So this is our 10th face-to-face annual immunisation conference. We had a few virtuals in there with COVID, but 10 is a really significant achievement, and it's a genuine privilege to stand here and welcome you all to this event. And even more special this year that our conference coincides with World Immunisation Week, with its global focus on for every generation, vaccines work. This theme speaks directly to the work represented in this room, protecting people across every stage of life in every corner of our communities. With this conference running for such a long period of time, it is something worth pausing for. And I want to start by asking a simple question. Why do we keep coming back? Why does this event not only endure, but continue to grow every year? Is it the scones at morning tea? Is it the beautiful orange autumn weather? Is it a precious day away from your clinic to meet with your colleagues? And while all of those might be true, what I have seen year after year of coming to this conference is something much deeper. Everyone here cares. You care about children being well. You care about protecting future generations from preventable diseases. You care about your communities not having to experience outbreaks that we know can be avoided. You care about maintaining and improving your clinical skills. You care about staying up to date, evidence-based, confident and capable. And you care about maintaining and increasing our already strong vaccination rates, which are some of the highest across Australia. But above all, you care about your patients, how you keep them well, how you listen, how you respond to fear and uncertainty, and how you build trust, one conversation at a time. And this is how vaccines work, not just through science, but through relationships, confidence, and care, generation after generation. What I have also seen over the period of this conference is a genuine commitment to working together. Immunisation is one of the true cornerstones of public health, but it is not delivered by systems or strategies alone. It is delivered by people, by nurses, by Aboriginal health practitioners, by public health teams, by educators, by GPs, by pharmacists, with policy advisors, with program staff, all playing different roles, but all pulling in the same direction. And this is collective stewardship in action, the idea that protecting our communities today and for the generations that follows is something we all hold together. And then there's the program that is on show today. It speaks to the public health forces shaping the year ahead, emerging and re-emerging infectious disease risks, Aboriginal immunisation and community-centred approaches, using data and systems well, managing complexity and supporting people to be travel ready. But there are many moments that aren't on the program. There's the hugs between colleagues who haven't seen each other since last year, the quiet check-ins of how are you going, the conversations that end with, I can help with that, I'll get in touch, the laughter at morning tea, the chatter over lunch, the stories shared between sessions. These moments all matter. They reconnect us as humans. They give us permission to step away from the day-to-day pressures of clinical work. They allow us to refresh, reflect and learn, and hopefully return to our communities ready to take on the challenge again. Sustaining immunisation effort across generations requires not just skill but connection, and that's something that everyone in this room does exceptionally well. These immunisation conferences also don't happen by accident. There is a dedicated group of people who spend countless hours each year bringing this event together, shaping the program, responding to feedback, and ensuring it remains practical, relevant, and grounded in what you actually need. I want to sincerely thank our Western LHD and Public Health Unit colleagues, whose leadership and partnership continue to be central to immunisation across Western New South Wales. To NCIRS, who support this conference year after year with nationally respected expertise. It is always a pleasure to welcome you to our region. And to our immunisation and education team at the Western New South Wales PHN, whose commitment to quality, innovation and continuous improvement is evident in every detail of today's program. The dedication to this growing event and evolving it as the immunisation landscape changes is outstanding. And before we officially begin, I would also like to thank each and every one of you for the work that you do every day. Our health truly is one of our greatest assets, and it is because of people like you that our communities remain protected, supported, and safe. On behalf of Western New South Wales PHN, please know that we are here to support you as partners in this work, as together we continue to break down barriers, strengthen confidence, and protect those most vulnerable. Thank you for being here, thank you for caring, and thank you for being a part of the story of this conference. And I hope you all have a wonderful day of learning, connection, and celebration. Thank you.
Thank you, Katie. So each year, this conference is made possible through the valued and long-standing partnership between the Western New South Wales Primary Health Network, Western New South Wales Local Health District Public Health Unit, and the National Centre for Immunisation Research and Surveillance, aka NCIRS. A collaboration we're all incredibly proud of. So our shared purpose is simple: to bring together immunisation providers from across the region for a day of learning, education, and a scrap of fun, as we say. So we're glad you could all make it today. And of course, today we're fortunate to welcome an outstanding presenter lineup, including cloud favourite, Dr. Archana Koirala. Give him a wave, Archana. So this year, Archana is joined by her colleague, Dr. Annie Huang and Lauren Dalton. So please give the incredible NCIRS team a warm orange welcome. And we're also delighted to have our exceptional Western New South Wales LHD Public Health Unit team with us. So Dr. Victor Carey, Priscilla Stanley, Kendall Ball, Wendy Holmes, Alice Gordon, Kim Rice, and Fiona Quinn, with Belinda Tracy stepping into a facilitator role this year. Thanks, Bill. So please join me in welcoming them in as well. Okay. So before we get into the presentations, just some housekeeping. Now, if you happen to arrive in the hall via different arm and you didn't get to check in and get your lucky door prize, please see, Erin's got a hand up there in the corner. Please see the PHN team and they'll check you in more formally. So presentation slides will be shared with you all next week. For bathrooms, if you exit through this door, we've got bathrooms to the left and the right. And in the event of emergency, I'm assuming that an alarm will go off, please follow the PHN staff for instructions. And a quick reminder to pop your phones on silent, please. And a note that today's conference is being recorded. Photographs will be taken throughout the day for social media, reporting and other communications. Now you'll find the program, presenter bios, evaluation and Slido QR codes on your table. Hopefully, if you don't, again, see one of the PHN staff. Slido will run throughout the day for questions and interactive activities. So please submit questions at any time via the Slido audience Q&A tab. Keeping in mind that our presenters will join us for a dedicated Q&A session at 3:30 this afternoon. So you can also ask them with roaming microphones. So morning tea will be at 10:20 and lunch at 1:05 if all goes to plan. So this year we're going to shake it up a little bit, get you moving. Right? We're not going to rely on caffeine this year, although that helps. we've got Who's Who in the Room interactive activity. So to kick things off, let's get a little curious and take a moment to celebrate Who's Who in the Room. So I'll call out different work settings. If that's you, please stand up, don't be shy. So we can all acknowledge, with a round of applause, the wonderful diversity and immunisation experience we have in the room today. So please stand up if you work in general practice. Wow, look at that. Vital, thank you so much. Aboriginal Medical Services. You're here. You're here. Aboriginal Community Controlled Health Organisations. Similar? Yep. Child and Family Health or Community Health Teams. The front, yes, wow. Fantastic. Look at this. Wonderful. Thank you all. Hospitals. Yes. I was going to say Archana. Yep, definitely. Yep. Schools. Yeah, well represented. Of course, fantastic. Pharmacy. Yeah, pharmacy friends. In spirit. Justice Health. Yes, well there you go. Fantastic. Residential aged care homes. Flying solo, well done. And finally, who have we missed? Please stand up if we've missed you. If I'm not called out. I haven't said public health unit. Would you like me to say public health unit? Public health unit. Yeah, of course, of course. All right. Thank you all. That just goes to show the diversity in the room. So thank you so much for being here today. It's amazing. Now, as I said, we're going to spice things up. We've got another activity. Some of you may be curious as to what this is doing. Okay, on your table, yes, there's an activity which will run throughout the day, but let me explain it. It's called Getting to Know You Bingo. Yeah, we're in an RSL club. We're going to throw a bit of bingo at you, okay? So now that we've seen the great mix of people here today, let's spark some new conversations. So as I said, you'll find these Getting to Know Bingo strips on your table. Please take one each. So there should be one each. Again, if you don't have one, see the PHN team. So it's a light-hearted way to break the ice and encourage a bit of mixing and mingling throughout the day, a bit of conversation. No pressure, have a wonder. Say hello to someone new and get their thoughts on the conversation starter. Then move on to find different people who match clues on the next 3 tiles. Wrap things up by finding a trivia buff who can answer the final question. So that's the very last one on the end there, okay? So the first 3 people, so this is why it's bingo, people, okay? The first 3 people to finish and call out bingo wins nothing. No. You'll win a prize. You'll win a prize. And if you're keen, and we hope you are, we'd love to hear a couple of fun things you've uncovered when you come up to collect your prize at the end of the day. So this will be at the end of the day. So jump in and have some fun, more importantly. Okay. So that's the fun activities for today. Transition to Education program. So these new connections, along with a shared sense of purpose and learning, we're exactly what today is all about. And with that in mind, let's move on to our first education session. So I'm delighted to welcome someone we all know, Priscilla Stanley, Director of Public Health with the Western New South Wales Local Health District. So Priscilla will share a public health pulse check, what's happening in the year ahead, highlighting the key and emerging public health issues influencing our region this year. So Priscilla, welcome to the microphone. Your clicker's just there.
Big green,
Big green.
the big green one, okay. I think I can do this. The only challenge, I think I said I had this challenge last year. I need the glasses to read, but when I have them on, I can't see you. And I think it's more important that I see all of you. I did think of another group that we didn't get to stand up, and that's the AHPs. Can we get AHPs to stand up? 2. Oh, yay! Okay, big clap. You'll learn all about the role AHPs play, the really vital role AHPs play in the immunisation space throughout today. And I encourage you to talk to Wendy and Alice, a part of the public health unit. And there was that a flash I just saw, or am I having, no. And there was another AHP that stood up down the back that I'll come and say hello to at some stage. So come and find me. I will say I'm not staying for the whole day, unfortunately. I'm going to do a bit of a half and half here and then half in Dubbo tomorrow. But I'm meant to be presenting on something here, so I better get started. I did also want to acknowledge that it's International Denim Day, so for all of you wearing denim, did you know that you were wearing that for a cause? You did? Oh, okay. Here I was thinking I was coming to educate everyone, and I, last night, thought, how can we tie in Denim Day with what we do in immunisations? And for those that don't know, Denim Day, look it up, just Google it and you'll learn all about it. It started as a global response to a harmful myth that what someone wore would imply consent. So people wore jeans to stand in solidarity of the survivors and to challenge that misinformation that causes real harm. And for the start of International Denim Day, that was real harm. So in public health, we face a similar challenge with immunisation isn't just about delivering vaccines, it's about confronting the myths, which seem to be more and more prevalent nowadays, building trust, which is something that I don't think we really recognise in ourselves, that we're a really trusted workforce. And I'm saying we, I actually mean all of you. I'm not sure about me, but I hope you all trust me. And ensuring decisions are guided by evidence, which is what we do in health. Everything should be guided and based in evidence. So just as Denim Day calls for us to stand visibly for truth and dignity, our work in immunisation asks us to do the same, because misinformation doesn't shape opinions, it shapes outcomes. When I jotted that down last night, I thought, well, that's pretty much my presentation done. Do I have a bell? Because as we know, I'm not good with timing. Okay. No data this year, which is a really good thing because data really gets me quite confused, and there's so much that it's actually really hard to take it all in. So I really just wanted to stand up here and firstly thank the PHN for another year and putting on this conference again, and our colleagues at NCS. It's so good that you make the trip over the Great Dividing Range and come and visit us in the country where we, and I do say that from all regional, rural, remote people, it's always wonderful seeing our Sydney counterparts come out and having to navigate Bell's line of road now that the Great Western Highway is closed. Crazy stuff. And obviously my colleagues and team in the public health unit. So I thought what we'd do is just state the bleeding obvious, talk about how important immunisation is. So I really wanted to go through a few little slides to talk about where we're at, what's influencing immunisation, and some key takeaways at the end. So we all know it, immunisation remains one of the most effective preventative health interventions available. Its impact is amplified in our rural and remote communities where access is really challenging. And sometimes that access is an issue in even our big regional centres for some parts of our communities. The health risks in a rural setting are often compounded by the geography, by climate and what's happening with whether we're flooding or, dare I say it, for anyone who's on the land, you know this all too well, heading into drought conditions and social factors. So in Western New South Wales, our immunisers are not only clinicians, but they're trusted community figures who influence health behaviours through the relationships that you build. Moving to, okay, well that's not going to work for me. I am pressing the big green. Oh, here we go. So I've talked about the trusted clinical care and the advocacy roles that you will play. So with what's happening across our district and across the state and country and internationally, there is going to be a greater emphasis on your role as clinical providers and public health advocates. And I kind of think that's really exciting because one of the wish lists for public health is that we get more and more staff in our team, but we actually have all of you as part of the public health team and the work that you do in protecting our population. The other aspects that we know only too well is that prevention reduces the system strain and the more people that we administer vaccines to for vaccine preventable diseases, we potentially limit there goes that flash again. I'm sure it's flashing. Anyway, sorry, for those presenting, get ready for it. It's really distracting. And obviously equity is an important priority for sorry, I've jumped ahead a slide. The prevention, reducing the slide, and that equitable access for our priority groups. And the increase in that opportunistic vaccination, so whenever someone is at a touch point with any of you, if it's for some other reason, it's an opportunity to look at their immunisation status and use that opportunity to vaccinate. So priorities for 2026 are clearly outlined here with prevention, equity, and that preparedness and maintaining standards. The equity is obviously a really important aspect for all of us in the rural areas, but particularly those that do have challenges accessing healthcare. And with more and more providers available across the district, that is not as great an issue in some parts, but of course it's still an issue. The preparedness and practice standards are obviously, we need to mention the post-COVID period and that maintaining our readiness for something that might happen again. And as much as I have said, the moment something like that happens again, I'm walking out the door, I'd still have a mortgage to pay, so I probably will stay working. And the reality is it probably will happen again in most of us in our working life. Globally, there's lots happening globally, and it's kind of all too depressing to talk about, to be honest. Those global impacts influence and have an impact on us in little old Orange and communities around here, plus much further abroad. So our car trip down, we learned how much Alice had to pay in fuel the other day. And believe it or not, that impact and that flow on with our fuel crisis has an impact on our delivery of healthcare. But importantly, the other impacts are those outbreaks that are occurring, and you would all be aware of the measles situation. A lot of those cases are coming in from overseas, so people who are lucky enough to travel overseas but unlucky enough to bring measles back with them, and then really unlucky for people who haven't travelled that end up with measles. There's probably some of you in this room that have experienced measles, not personally, but possibly seen measles. And as much as I'd love to say that it's a disease we won't see. It very well may be now. So brush up on measles and what to, obviously vaccinate if you can, but brush up on what it looks like and how it presents, because you may very well see a case. The other interesting disease that's causing a little bit of grief up in Northern Australia is diphtheria. So that's obviously another vaccine-preventable disease, and there's a little bit more to diphtheria with the toxigenic strains, etc. So the climate is something that's having an impact, and with warmer temperatures and extreme weather, it's all has an impact on health. And then, of course, the system pressures. I think I accidentally jumped through. What's changing on the ground, and really I'm going to say stuff here that you are all experiencing, and if you haven't experienced yet, I'm sure you will experience, and that's those more complex conversations you're having with individuals. People are questioning a lot more, they're doing a lot of their own research. Unfortunately, social media and the internet doesn't necessarily provide the right information. So you're challenged with all of those complexities and the interesting questions. 1 minute to go. Okay. The access and disruption to pressures that impact us in the rural setting. Great Western Highway closing is a perfect example. Thankfully, there is one other road over the Blue Mountains that can get us to and from Sydney and stuff to and from Sydney. And people. The expectation for flexible delivery too. So the days of just a clinic, immunisation clinic, we need to evolve and move on from that and provide immunisations at any opportunity. This is, again, all the obvious. What's not changing is that vaccines will remain essential. We need to continue to provide our care in a culturally safe and respectful way. That trust in immunisation providers isn't going to change and will increase and improve with time and with more and more providers becoming available. And obviously quality and safety is a non-negotiable. So, last slide. I have done well this year. 4 key takeaways. Every vaccination is prevention in action. So thank you all for joining the Public Health Unit. I hope to get to know each and every one of you by name. I thank God for name tags, so make sure you're wearing them. And I'll carry my glasses at all times. Just remember that every conversation you have with individuals in our community does matter about immunisations. Just be sure that people take on board what you're saying and the information you're providing. Immunisation providers strengthen the resilience in our system. And so your role is actually, believe it or not, sometimes I'm sure you think you're just an immunisation provider in your clinic and that's what you do, but you're doing something that is vital for the entire system. And of course what we're doing is aligning our practices with the priorities for New South Wales, the New South Wales health priorities, the priorities for our LHD and protecting the people within our communities, yourselves and those within our communities. So have a great day everyone. Look forward to meeting some of you and chatting to those of you that I do know, although I'm looking out at a sea of strangers at the moment. The spotlight has dazzled me. I hope you have a great day and enjoy.
Thanks so much, Priscilla. Bingo! Oh, really fantastic! Now, you were the one that stood up that we didn't name. Do you want to do us the honours, please, and tell us? Angela. Thank you, Angela. You can, I don't know, wait, bingo. You can go see our good friends at the PHN, Erica there with a hand up. Go see her during the break. Now, I couldn't help but notice, Priscilla, during your presentation, I've got a theory. Those flashes could be stealing my job because they were timed perfectly for your 5-minute warning and your 2-minute warning. So were you paying attention? So for the future presenters, which that flash might be telling you something that I can't off to the side there. So, which leads me to our next presenter, something a little bit quite exciting: rabies and Australian bat lyssavirus. Please join me in welcoming Dr. Victor Carey, Public Health Physician, Public Health Unit, who will provide an update on rabies and Australian bat lyssavirus.
Thank you.
Thanks, Doctor. Hopefully that's not working. It's not. They can move the slide.
Thanks a lot. Look, today what I'd like to do is take a problem and look at it from a slightly different perspective. We, and you in particular, work trying to, in a routine or opportunistic way, deliver something which is going to prevent something that may happen in the future. So vaccines. What I want to talk about is something bad may have happened. And trying to work out, is it bad? That's the first problem. And secondly, what can we do about it to prevent that bad thing happening? So it's post-exposure prophylaxis. So trying to either actively or passively immunise someone who's had an event that could bring a significant risk of death. So I'm going to present some information, and this is a complex problem often, trying to work out, well, is this a real risk or not? And if it is, what exactly do we do? It's all covered, you'll be pleased to know, in the Immunisation Handbook, amongst other resources. And really the detail that I'm going to present is not important enough for you to have to remember. It's really just an awareness of this and a knowledge that the Public Health Unit actively manages these sorts of incidents on a daily basis, because they happen not infrequently. And if you have a patient or a friend or a relative and you want some advice, you should ring the Public Health Unit, because we have staff who are much more familiar with how do we work all of this out and what do we do, and if we need to do something, how do we get access to vaccines or immunoglobulin to treat that patient. So I think that's actually the most important thing I'll say today, but I will say the rest. Now, rabies virus and Australian bat lyssavirus, they're really from the same family. They're from the same genus of lyssavirus. And all of those viruses cause a rabies-like illness. We know that if you think about globally, dogs cause the most rabies disease globally. And there are other important mammals which do carry this disease and pose a risk if you're bitten. But we don't have mammals in Australia that carry rabies, which is very fortunate. But we do have bats. And in May 1996, Australia bat lyssavirus was identified in an unwell bat, flying fox in Queensland. And subsequent to that, it's been identified in all 4 species of flying fox and 1 species of microbat. Next slide, someone. Seems not to be working now. There we go. So it's important to know that rabies is transmitted via the saliva of an infected animal, and that's introduced either by a bite or a scratch, or by contamination of mucous membranes or broken skin. In some regions, bats are now becoming the major source of rabies in some countries, and including Australia. Exposure to bats, we know, is quite common, and we in New South Wales probably more than 100 incidents a year which require follow-up within a public health unit and prophylaxis. It's important to note that exposure to blood, urine or faeces from a bat is not considered an infectious risk, so it's really a bite or a scratch and the potential for saliva to get into that wound. The incubation period is usually between 1 and 2 months, and the length of that period depends on many factors, such as the wound severity, the wound location in relation to the nerve supply, and we'll see why that's important in a minute, the proximity to the brain, the size of the inoculum of virus, so the amount of virus that's being contaminated into that wound, and the degree of protection provided by clothing and other factors. So looking at the figure on the right, so you're bitten by an animal, in this case a dog, and the virus enters via that bite, and then it multiplies in the muscle around that bite area. And then the virus infects a peripheral nerve, so a nerve near where you got bitten, say on your leg. And then that virus travels up that nerve to your spinal cord, and it multiplies again. And then that virus ascends in the spinal cord to your brain, and your brain becomes infected. From there it can infect other organs, but it's really the infection of the brain that leads to the encephalitis and the neurological symptoms. People present initially with fever or sensory changes, so tingling, itchiness at the bite. And other sort of symptoms early on include apprehension, headache and malaise. But then there are 2 clinical forms which may develop, and most commonly encephalitic, which is called furious rabies. And that includes hyperactivity, agitation, confusion, insomnia, hallucinations, hydrophobia, so painful involuntary spasms of the throat when trying to drink, and gradually coma and death. I did see a case of rabies in the Philippines at the tropical hospital in Manila, and it was really something. I mean, there's nothing you can do apart from sedation, and it was a frightening thing for the patient, of course, and relatives and staff. Now, rabies is almost always fatal. So once you're symptomatic, once you've got rabies, there's not a lot you can do. It's fatal. Which is why any actions we take are critical in preventing that. I'm just going to read some case histories because there have been now 4 deaths from Australian bat lyssavirus in Australia. The first case occurred in November 1996 when 39-year-old Patricia Paget, an animal caregiver in Rockhampton, sustained severe scratches from a bite from a yellow-bellied sheath-tailed bat in her care. She reported to the hospital 4 to 5 weeks later for shoulder pain, dizziness, vomiting, headache, fever, chills. Whilst hospitalised, her condition rapidly deteriorated with slurred speech, double vision, difficulty swallowing and progressive weakness of her limbs. Hospital tests, including PCRs of cerebrospinal fluid and EEGs, found that she had a diffuse encephalitis. She eventually fell into a depressed, conscious state with a single incidence of extreme agitation. She died 20 days after her initial admittance, and Australian bat lyssavirus was identified post-mortem from brain tissue. The second case began in August 1996. A 37-year-old female from Mackay was bitten on the finger by a flying fox at a birthday party whilst attempting to remove it from a child on who it had landed. 6 months later, following heightened public attention due to the first case, she actually went to a GP and said, "Can I have testing for the virus?" Unfortunately, post-exposure prophylaxis was advised, but for unknown reasons, she declined that treatment. After a 27-month incubation period, a rabies-like illness developed in November 1998. She came in with symptoms of fever, vomiting, shoulder pain, dysphagia and muscle spasms. Her condition worsened and she became ventilation dependent and unable to communicate due to full paralysis. On the fourth day of her hospital admission, a diagnosis of Australia bat lyssavirus was made. She died 19 days after the onset of the illness. The third case occurred in December 2012 when an 8-year-old, Lincoln Flynn, was attacked by a bat. He didn't tell his parents. He became ill 8 weeks later, showing symptoms including fever, anorexia, abdominal pain. His condition worsened throughout his hospitalisation. He had some aggressive bouts and some normal periods. Anyway, eventually he needed to be intubated, sedated, and he passed away 28 days after the onset of symptoms. The fourth case is more recent, and that's from New South Wales, where a 50-year-old man was in a critical condition with Australian bat lyssavirus after being bitten by a bat several months before. He actually had appropriate post-exposure prophylaxis, and it seems to be an extremely rare case of post-exposure prophylaxis being ineffective. There have been a few documented cases globally, but generally we know, because there are a lot of bat exposures in Australia, and we've only had these 4 cases. What animals attack? So these are data from the information system that public health units use across the state, and it's from 2013 to 2025. Over 7,000 cases we've been involved in, public health units, looking at what was the source of the bite, not the infection. These people aren't infected, but this is, we're alerted, we become involved in trying to manage that case. And you can see there that 65% are from overseas and they're travellers, and Annie is going to talk about travel vaccination later this afternoon and talk about pre-exposure prevention, which is great. The take-home, if you're going overseas to a rabies endemic area, really think about it, but I'm sure you'll talk about that. 35% from Australia, and the bats in that graph are from Australia. And the overseas ones, mostly dogs. So before I go on to this, and this is in my slides, what to do if someone is bitten. The first thing, and it's not in the slides, the first thing you should do is thoroughly clean the wound. So wash it with soap and water for 15 minutes. And then apply an antiseptic with antiviral properties, something that contains iodine. And don't cover the wound. If it's in the eye, if there's some exposure in the eyes or the nose or the mouth, flush with water. And that person should see a healthcare worker because it needs to be assessed. You can clearly see the wound now because you've washed it so well. What's the significance of that? Well, any bite, scratch, or mucous membrane or broken skin contact with the saliva of an infected animal is a risk. So a bat in Australia, a wild or domestic animal in a rabies-affected country. The principles of post-exposure prophylaxis, and it's very important, the type of exposure, the severity, the age of the individual, details about the animal exposed to, the time since exposure, and whether that animal is available for observation, because you can actually, if that animal lives to 15 days, then you can assume that there's no lyssavirus in that. This is where it becomes complicated. It's really important to determine what sort of injury it is because it guides what we do next. And a category 1 exposure is touching or feeding animals, licks on intact skin, as well as exposure to blood, urine or faeces, or to an animal that has been dead for more than 4 hours. Category 2 is nibbling of uncovered skin, minor scratches or abrasions without bleeding. And category 3 is bites and scratches with blood. You'll see why this is important. Now, don't be scared of the detail here. The important thing is this. If it's a category 2 injury, that is scratches, nibbling, and someone is not immune, they've never had rabies vaccine, then they need vaccine in a certain schedule, but they don't need rabies immunoglobulin. If they're previously immunised, they need vaccine and they don't need immunoglobulin. This is not for bats, this is for bites from overseas. If it's category 3 and they're non-immune, they need vaccine and immunoglobulin. And if they're previously immunised, they need vaccine but no immunoglobulin. Bats, on the other hand, there's a difference. Both category 2 and category 3 need vaccine. If they're previously immunised, they just need vaccine, but if they're non-immune, they need vaccine and immunoglobulin. Very important. Giving rabies immunoglobulin is not the most pleasant thing, either to the patient or the person having to give it. It's usually supplied in 2 ml vials, and the following formula can be used, and I've worked this out for a theoretical person like myself who may or may not weigh 100 kilos. I may need 2,000 international units, and if we divide that by 150, I would need 13 mils. 13 mils, and it's a bit viscous. And the recommender, and that's 7 vials. It's actually 6.6, but let's say I was a little bit more in theory, and just posing this a little bit more than 100, that might be right. I'm not saying that's the case. They recommend that as much as you can of that is injected around the site of the injury. As much as you can around the site of the injury, and the rest then intramuscularly at a site opposite to where you're going to give the vaccine. Life becomes even more complex if someone's been bitten overseas and has started prophylaxis overseas, let's say in India or the Philippines or Thailand, and common places for people to return to with this complaint, and it might have been a dog or a monkey or whatever, and they've started on something, and often you don't have a good information on exactly what they've been given. Sometimes you're lucky and you do. You don't know what brand of vaccine it is, because that affects what you might do. Is it a cell produced vaccine, or is it a nerve tissue produced vaccine? Have they been given immunoglobulin or not? And so there's a complex sort of assessment that we would do in the public health unit to try and continue effective prophylaxis for that person. But it's really important that we become involved early. So as soon as someone like that turns up, and some of you will have experienced it, return travellers, and ring us, please. Whoops. So, doctors and all healthcare workers really should contact the local public health unit for advice on potential exposure to rabies or Australian bat lyssavirus. There's the number. Any case where rabies or ABLV infection is considered as part of a differential diagnosis should immediately be reported to the PHU by phone. We will order the vaccine and the immunoglobulin for that practice, and we will give you advice on the schedule. So, it's very complex, but the important thing is we're actually, if you ever come across this in where you practice, we're here to help you every step of the way, because it's something that we do frequently with return travellers and exposure to bats. So thank you.
Many thanks, Victor. Message received. Do not touch the bat. Yes. Yeah. Prevention's better than cure. Okay. I now invite Wendy Holmes and Alice Gordon from the Aboriginal Immunisation team, who will share some important news in the Aboriginal immunisation space with a focus on recent changes to the authority and standards for Aboriginal health practitioners to vaccinate. Please welcome Wendy and Alice.
Where are we? Hello, everyone. I would firstly just like to thank Uncle Neil for his welcome to country and acknowledge that we are on Wiradjuri lands today. And just a quick introduction, I'm Alice and this is Wendy. We are Aboriginal health practitioners working for the Public Health Unit. And today we're just going to share a bit of a story about some changes to the authority. We did start the presentation today with the changes, but I might take a step back and just explain it from the start for those who are unaware. We do a medication component in our studies to be an AHP, and there was a dear little paragraph in the authority that prevented us from administering medications. During COVID, this was changed, and then when COVID ended, it was rescinded. With this change, we thought, well, we know you can change it, let's fight for some different changes. There were some AHPs who had done the immunisation course, and Western had fought for these changes. So initially in 2024, the authority changed again, and we're allowed to administer flu vax from 5 years and older. And then most recently, a few months ago, these vaccines you see on the screen are the additional changes. And that's the background, that's just the change of the authority, the 4th of March, there you go. The authority change, and also the age from flu is gone from 5 to 2-year-olds. So Wendy and I cover 47 communities across Western and Far West New South Wales, and that's 14 different traditional Aboriginal clan groups. We have advocated, we have done lots of different things from immunisation to even some environmental health stuff in the lands that we cover. And those little dots you see are actually where Aboriginal health practitioner immunisers sit. So if you are in any of those communities, just know that there is an AHP immuniser there, and invite them to different things that you do involving immunisation. Okay, where are we? This is our beautiful team that fought to have it changed. That's a couple of our immunisers and nurse educators there. All right. So Western led the way for this whole state change. We now offer, I think, monthly education sessions at a statewide level, and give information to other AHPs across the whole state on what we've done, how we've done it, and where we're going to next.
So, first of all, there was a pathway. We had to go through our online MHLs, and we made the Aboriginal Health Package, education package, that now has been adapted through the Ministry of Health. So, all the ones on there is what we have to complete before we can go out and vaccinate. So when an AHP's first finish their immunisation course, they have to be supervised to do 10 vaccines in a clinic. So the outcomes and the impacts. So as you can see, these are when we first started back in 2024-25, this is some of what the AHPs had to say about it. The support that was given by the Public Health Unit, amazing role models. So I'll just let you read through them anyway. And then wanted a checklist, which is what we have on the next page. So now what we... so we've made up a vaccination checklist, which the Ministry of Health has adapted that as well. We have our Shirley Ann, who's one of our AHPs out in Condobolin, running a clinic there with Bluey, as you see. So this is our checklist, so we make sure that we have all this here if we go out to vaccinate. This is one of our outcomes. We've got Alice out vaccinating in Brewarrina. These are like just small halls that you can see in the middle of nowhere where we set up clinics. That's me vaccinating. That was when I first started in 2024 when the authority changed in June. Our role beyond the flu vaccine, so as now, we've always been out helping with the school vaccination clinics, but now we can actually go out and vaccinate in them clinics as a second person. We share our knowledge with the vaccines and safety. We support and promote childhood, adolescence and vaccinations. We can now get verbal consent, historically where we could ring the parent but we had to hand the phone over to herein immuniser, obtain the consent. So that's made a big difference in the schools. We're also super users with AIR and CARMI, so if you need any help, Alice and me's your go-to. And we monitor AIR data, ensuring our kiddies remain up to date as well. And that's it. Thank you.
And if you know any AHPs that want to do the course, let us know.
It's fantastic work, both of you. That's awesome. Okay, so a very catching title for the next session. Catch-ups, catching up before bugs catch on. Now, this is a Slido activity. Please join me in welcoming Kim Rice and Fiona Quinn, clinical nurse consultants with the Public Health Unit, who will present catching up before bugs catch on and take us through some practical catch-up scenarios using Slido. Thank you both.
Hello everyone.
Thanks for having us back again.
I went to pick up Fiona this morning from home and we didn't really talk about what we were wearing, and I could see her come out to the car and I went, oh, okay.
In all fairness, we did have a pretty big day yesterday.
Yeah, we did.
Yes. So today you have to put up with the beautiful slides I've made with bugs all over them.
I know, we worked on this together and clearly Fiona did the decorations.
Yeah, the paediatric nurse comes out and is so sorry.
So we've been asked to do catch-ups, and I know we do it every year, and I thought you'd be all really, really sick of it, but apparently the feedback said
More.
you want it again, so we're here again doing it. So, yeah, because falling behind is for Netflix shows, not for immunisations.
So, will I try this and see if it works for me? Nope.
Will it work? Everyone's struggling with the
Yeah.
button. Oh, now I've gone too far.
Oh, look, we've given away stuff.
Okay.
Right.
Okay.
Maybe we should have already had morning tea before us.
So why do we do catch-ups? And why are they different according to age? Well, catch-up immunisations, it isn't a one-size-fits-all. And I know I have talked to a lot of you on the telephone and I have a lot of email correspondence with a lot of you. Please today, because I know all these names and all these GP practices and early childhood centres, but I don't know your faces. So if you could come up to us.
Yeah, please come and say hi because we
during the day, because I feel like I know you as a person, but I don't know your face.
Yep.
So
and we know that these can be quite complex, so it's really nice to have a great relationship with you guys to get these catch-ups sorted.
And what I like to say to people, there's not just one road to Rome. Like sometimes catch-ups can be a little like you know, you might have two people organising a catch-up, and it can be a little bit different, but we all get there in the end.
Yeah.
And the type, and so why it is not a one-size-fits-all is because the type, the number and the timing of vaccine changes depending on whether the person is under 10, an adolescent or an adult. So this is based in differences in immune development, vaccine schedules and what is recommended or funded at different life stages.
Yeah. And obviously what they've had in the past. Yep. Right, I'm going to try this one again. Oh, it worked. All right, so catch-ups for children under 10. So the handbook is like your guide. Even if you ring us, the first place we are going to is the handbook. We acknowledge that the handbook can be a lot, as you could see in Victor's slides with the tables and stuff. I do understand that when you're busy, sometimes you look at them and you go, oh my God, this is too much. Just ring us, we're fine to have a look at that with you. We know that some children require multiple vaccines in early childhood. That's just around boosting immunity in the antigens, but we know sometimes when they come from overseas or they've missed multiple ages, that it can seem like a lot to give those vaccines. And often we are recommending like 4 and 5 vaccines at a visit based on the schedule, which for some people I know is a scary proposition to give that number of vaccines to. We obviously are looking at minimal intervals as well around those vaccines, and making sure that any evidence the family has of previous vaccines is counted, so that it's okay to give another dose of something, it's just boosting immunity, but if we don't have to give that injection, then we are going to avoid that if we can. So the evidence that you supply us and the family supply us make a real difference in where we go with under 10-year-olds.
Okay. Did it work? Oh,
I just have to like stand on one foot and... Right, let's do this and see. There we go. I've got to point my time. Yeah.
So I just thought I'd put little different, rules with catch-up. So your wave good. So the childhood vaccines, Inferex Hexa, Inferex IPV, Vaxelis, Tripicell, Quadricell. You wave goodbye once you turn 10. So I know we organise a lot of catch-ups, and people go, why can't we? You might have 11-year-old, 12-year-old, and you want to use some of these childhood ones because they've got more antigens in the vaccines. But once you turn 10, you've got to say bye-bye to the childhood ones. And we say that because the formulation for age 10 and up and the catch-up vaccination for diphtheria, tetanus and pertussis switches from the childhood formulation to the reduced antigen adolescent adult formulation. So we can't... So once you turn 10, you've got to flip to the adult ones. So I was sort of thinking something that you can remember that. So once the 10th birthday rolls around, childhood DTPA vaccines, you can pack their tiny suitcases, put on the sunnies and say goodbye.
Hit double figures, they're adults.
Yeah.
Yeah, you can.
Oh,
I know.
now I've lost this.
There we go. And so moving on to Hib and pneumococcal, they go at 5 years. So we talk about they need 1 dose after 12 months, irrelevant of any other doses they had before that. And if they haven't had any by the time they turn 5, we don't give any boosters. So you can say goodbye to Hib and pneumococcal vaccines at the age of 5. And that's just around the early childhood risk factors and the uptake of those vaccines. So sometimes you'll send us catch-ups and you'll be like, they've only had 1 pneumococcal, and we're like, but they're over
5. So
5, they don't need any more, or they're over 12 months and they've had 1 over 12 months, so they don't need more.
And this is healthy children.
Yeah.
Obviously. Yeah. Okay, now another one that often we get is the MMRV. So your Priorix tetras, you can only use that. So what I was trying to think of catchy phrases. Sticks with you, but only until you're 14. So once you turn 14, you can't use the Priorix tetra. I know it's really convenient because little people come in and they need a measles, well, not little people, big...
Scared teenagers
come in and they need, you'll look and you'll say, oh, they need a measles, mumps, rubella, they need a varicella, happy days, we can give them a Priorix tetra. Well, actually you can't. Once you turn 14, no more, it retires. And so, yes, so from 1 to 14, MMRV is your one-stop shop, but note, MMR must be given as the first dose if under 4 years of age. And then once you're 14 plus, nope, you need the 2 needles.
We know this is a lot, and that's why you can always call us.
Yeah.
So, where to give multiple vaccines? So sometimes, like I said, they need 4 or 5 vaccines at the same visit, and that's just around bringing these kids up to date. If you're not giving the vaccines altogether, then you're potentially leaving them exposed for something in the meantime, and will you get that family back for other vaccines? So placement matters, using separate injection sites when you can, or making sure you've got that 2.5 centimetre distance between your injection sites, which on your little ones can be quite tricky at times. There are recommended injection sites by age, so we know from 12 months plus arms, legs up until 12 months, but if you're doing 4 or 5, you have to do arms and legs sometimes. So things around like giving Bexsero and Prevnar in the arm always from 12 months onwards. If you're doing multiple vaccines, they're the priority for the arms, those sort of little things. In the infants, making sure that you've got the right spot in the thigh muscle, and for the older kids, making sure that you're up the upper deltoid. And with the adolescents as well and the older adults, always the deltoid, never the legs for those older kids. Yeah.
These are one of my favourite things, is spacing. So vaccines on time, even when the people aren't on time. So a lot of you will come, like you'll ask us for a catch-up and we'll organise a catch-up. But then it's really annoying because the people are late and then they don't come the second time on time. Or it all gets jumbled. So it's very good to think about minimal intervals between doses. And one of the important ones is the spacing between the diphtheria, pertussis and tetanus-containing childhood vaccines. So there's minimal intervals that you should follow. So between dose 1 and dose 2, minimal interval is 4 weeks. Dose 2 and 3, the minimal interval is 4 weeks. Between dose 3 and 4, the minimal interval is 6 months. And then between doses 4 and 5, 6 months, unless the child received dose 4 at greater than 3.5 years of age, then dose 5 is not needed.
And that's just for DTPA, so don't forget if you're doing Vaccelis and Hexa, there's other components to that to take on board as well.
It's a lot to think about, I know.
Yeah.
And that's why you can always reach out to us.
Oh, Kim's favourite one is next, actually. This too, she skipped ahead.
Oh,
No,
okay.
she loves Hep B. So the Hep B rules, so sometimes we get these families from overseas, and they've had a birth dose and a dose at like 6 weeks and 10 weeks, and AIR accepts it. It's all about the minimum timing between intervals. So the dose 1 and dose 2 can be 4 weeks between doses. Ideally in Australia we're looking for longer than that, we're looking at that 8 weeks, but 4 weeks is a minimum. Then dose 2 and 3 should have 8 weeks between it. As well as dose 1 and dose 3 should have 16 weeks between it. We say 4 months, but 16 weeks because some months are 5 weeks. So sometimes, again, the catch-ups can get a bit tricky because you're working around all of those different intervals, and again, if you've got it combined with diphtheria, tetanus and whooping cough, then that actually changes how your schedules work as well.
And people don't come back when they...
No.
Yeah, like so you're starting off this catch-up schedule.
And you're like,
we've
you
all
can
been
come
through
back
it
in a month.
Yeah, and they don't come back then. So then you've got to work on it again,
Yeah.
So I sort of try and plan each visit at a time because
Yeah.
if they're late, they're possibly going to be late again.
Yeah. But if they come back late and you're thinking, I don't know if this still stands, then give us a call because we'll run through it again before you do the vaccines. That's fine. Because particularly with the little ones, they might have actually, they were overdue at 12 months, but now they're 18 months or even 4 years, and so their catch-up might have changed in that
It'll
time.
look different.
Yep.
Yeah.
Right. Next is some Slido fun, just to keep you awake before morning tea. So,
Any questions? Oh, so those questions at the
Yes,
end.
right.
That's right. Yeah. Oh,
We had the Adelaide bone marrow transplant send some vaccination requests, and they requested influence IPV be given post-transplant. I had to ring them.
oh, okay.
okay, yeah.
They look different to New South Wales, but because she's still going back to Adelaide for treatment, they said this is what we want to give.
Oh, and it was an adult. They must have wanted the stronger. Yeah.
Yeah. Yeah.
Yeah. And you would follow their advice. Yeah. Because.
Yeah.
Yeah. No.
Yeah, but you ring us too, and we're happy to work
Yeah.
through that with them. That was a question around giving IPV to an adult after a bone marrow.
It must have been something to do with the
uptake.
diphtheria, the
Yeah.
tetanus, and the whooping cough. Because it's
Yeah.
like they've started again. They've
Yeah.
been stripped of
Yeah.
all their. Yeah.
Certainly not a common scenario though.
No.
Thankfully.
Yeah.
Yes. All right.
Right. We're new to Slido.
Yeah, please.
What do we do, Erica? What do we?
There we go.
Announce the question. Any other? Yeah.
It's up. Oh yeah, it's
Okay.
up here. Right.
Okay. Okay.
So a few sort of really common but not tricky catch-up questions for you guys. So
Just to keep you awake.
Yep. A 13-year-old has had 1 dose of measles, mumps, rubella in childhood and no varicella. What are you going to give today? So we'll give you a couple of minutes to do that.
Are we all Slidoing? Yes. Yeah.
All right. Okay. All right. Good. I like to hear it's got some conversation going. Yeah. Okay. So looking back at our slides that we did in the past, we were talking about MMRV being okay up until the age of 14. So
Most of you listened.
most of
so
you
that's good.
remembered that. Yep. So Number A. There is actually nothing wrong with doing B.
No.
You can certainly do that if that's what you've got in your fridge.
Yes.
But if you have an MMRV, then that would be our recommendation, just to reduce the number of needles.
Yeah, because we love that.
Yep.
Yeah.
All right. Next one.
So do we...
That was my original pretty slide.
What are we doing now, Erica? Do we go on?
There should be 2 more Slidos, I
Yeah.
think.
Oh, here we go.
See, it's like we've not done this
Yeah.
before. Right, all right. Pop in your answers for DTPA catch-ups.
So what's the golden rule of DTPA catch-ups?
I can see a few people undecided. I do like panic, though. You're
Yeah.
welcome to say panic. That's okay.
Yeah.
And then call the public health unit. Yeah. All right. I think that's probably
we-
enough time. We can pop the right answer up.
Yeah.
Yay. Yep. Yep. So you don't actually need to restart everything. They just really need a booster because, again, particularly depending on their age, if they're over 10, they don't need any of the childhood catch-ups anyway. And just look at the spacing of your doses.
Yep.
Excellent. Last one.
Okay, a 3-year-old has a history of having Bexsero at 6 weeks and 4 months of age only. Identifies as Aboriginal. Can we offer a 3rd dose and will it be funded?
Yeah.
This is a tricky one.
I know, we didn't even talk about this one, so...
That's a tricky one, isn't it?
Yes. Well, I can see the numbers changing a little bit.
Yeah.
This is always an interesting one, this one, because it's always around the funding. Will it be
Yeah.
funded? Yeah. All right. Shall we put the answer up?
Are we... Oh, it's still...
Well, there's still people changing their mind. There we go. Yes, it is funded.
Does anyone know why is it funded?
Not because they're Aboriginal as such, but because it was started under the age of 2 for an Aboriginal child.
So catch up for Aboriginal... So Bexsero in New South Wales is for Aboriginal children, but you must start the schedule before they turn 2. And because that child had the 2 doses before they turn 2, they can have their 3rd dose funded.
At whatever age they are. Yeah.
Yeah. Sorry, I thought I'd throw in a tricky
Yeah.
one.
Sorry, because we didn't even talk about that, but it's nice to make sure you're awake before morning tea. Yes.
And I think that is...
We are going to wrap up.
Yeah.
There we go. Final thoughts. Catch-ups differ depending on previous vaccines, ages. There are obviously age limits we've talked about. There's timing issues between doses. Just look at the handbook. If you find the handbook overwhelming, call the public health unit. You'll get one of us. Kendall,
Kendall?
who's disappeared somewhere.
Yeah.
Or Anita at Far West. There's always someone around. And you are never annoying us. I get a lot of phone calls from people like, I'm really sorry to ask you about a catch-up again. That's our job. We like doing it. Give us a call. It's never a problem.
I love them, so it's all good.
More than me.
Yeah.
But the more you do them, the better you get.
Yes.
Yes.
Yeah.
Thank you, everyone. Hopefully
Thank you very
catch-ups
much.
was helpful.
Thanks, Kim and Fiona. You should consider a side hustle in advertising, I think, because catch-ups are for Netflix and not immunisation. I love it. Well played. Okay, so before you head out to grab a scone for morning tea and some beverages, we'd love to pause and capture a snapshot of the incredible commitment and immunisation in our region. So if you've been immunising in our region for more than 10 years, please add your name and total years and months service to the Slido word cloud, so over the morning tea break, and as you're doing the Get to Know bingo, that sort of thing. So please, time to stand up, stretch, mingle, conversation, word cloud, have a break, and we'll be back. Please be back ready to start the next session before lunch at 10:45. Thank you all. Love is in the air. I love it. This is my territory. Digital Health Manager. Air. We love air, don't we? Yeah, we love air. So please welcome Lauren Dalton from NCIS, who will present Love is in the Air. It's yours.
Thanks for having me, everyone. It's great to be back here. I haven't been here for a few years, but I've been in this space for a while. I'm not the Air. I don't work at the Air, but I do a lot of work with them. So please bear with me. But I've got a great team of people that contributed to this presentation from the Air team, both at Services Australia, who implement the register, and of course the Department of Health, Disability and Ageing, who set all the policy and background. So I made this a bit fancy by putting an image around the Air, but that's as exciting as this topic gets. And I'm just very glad not to be following Archana that I am on before her. I'd also like to acknowledge the traditional custodians of the lands that we're meeting on, and this presentation was developed where I work on the Gadigal lands in the southern suburbs of Sydney. So there's a few things to talk about, but before I start, I just wanted people to hazard a guess 10 years ago, so in 2015, how many vaccines were reported to the Air every year. Who'd like to have a stab in the dark? It's upwards from 1 million. Anyone, any higher bidders on 1 million? 2? 3? So 4 million vaccines were reported to the Air in 2015. And today, last year, 2025, how many would anyone like to have a guess at? 20 million, just over 20 million vaccines are reported to the Air every year. So it's really important that we report everything to the Air. We know that vaccines it's mandatory to report all of the NIP-funded vaccines, COVID, JE to the Air and influenza, but I'd encourage you to report everything to the Air. People don't want a statement that's missing something because it's not compulsory. Please report everything. It is mandatory. You will get at some time in the future, there will be follow-up of that. So please vaccinate and report as soon as you can. So I've just skipped that slide, but we'll come back. But, you know, I will go through a few things today. But these are some of the Air enhancements over the last 12 months that I'll touch on. We are really lucky in this country to have the register. It's a world-class register. A lot of overseas countries do copy our register. We do a lot of presentations to the Pacific region and Asian region on our register, and it's really seen to be a world-class register. But it is a register of information, and the information that goes in is only as good as the person sending it, so we've got to be really careful about that. But there's been updates being made all the time. For those who have been working here for 30 years, you'll remember how clunky it used to be and painful and just terrible, but enhancements are always being made, and I think we're in a really good place with the register, especially now with the interface with practice software. So these are some of the things I'll touch on today. Importantly, yesterday, and hence I caused a lot of pain to the people collating all our PowerPoints, we did have the introduction of new influenza due and overdue rules and updates to the pneumococcal due and overdue rules for First Nations children, which I'm sure you're all going to be very happy about, so I'll touch on that in a moment. But importantly, there's some really good things that I'm sure you're all familiar with, the minimum age warning messages for RSV and influenza vaccines. So if you report something incorrectly to the register for someone who shouldn't be getting that vaccine at that age, you will get that pop-up, both in your software and on the air, and it's really important that you look at that and say, did I give the right vaccine to the right person for the right age? If it was just a recording error, you can adjust that. If it's not, it is an administration error and you do need to follow your pathways for reporting that. And you'll see that FluMist has been added here. So if you're remembering, FluMist is only registered for people aged between 2 and 17 years, and Arch will talk about that more soon. But if you do report it to someone given less than 2 or over 17, you will get a red flag. And you do really need to do something about those red flags. Don't ignore them. This has been around for a while now, the antenatal indicator. So if someone's receiving a vaccine in pregnancy, you need to tick that box. It is all the vaccine in pregnancy vaccinations are NIP funded, so you can select NIP, and there's no more indicator in that other vaccine type for antenatal. So make sure you're using that. And it's really important because we don't have great data on vaccines given in pregnancy, and this is really going to help in that space as well. And importantly, just remember to make sure your practice software is always up to date, because that's when these new enhancements then go over into those things as well. So this is new. So who reads the air due and overdue rules? Does anyone ever look at those? They're not the most exciting bedtime reading, but they've just introduced due and overdue rules for influenza. And what that means, it is only for NIP eligible groups, but remembering that the air can't identify everybody. So they don't identify people who are pregnant, they don't identify people with an at-risk condition. So this mainly impacts children under 5, all Aboriginal and Torres Strait Islander people aged 6 months and over, and people aged over 65. So if an influenza vaccine hasn't been administered since 1st of March in the current year, a dose is due to everybody who is NIP eligible on the 1st of May. And they will then be considered overdue on the 1st of June. What that means in practice is that they will get an overdue letter. So they'll get a letter that says, and that is only for those who are NIP eligible, they'll get a letter to say, you're under 5, you haven't had a flu vaccine, it is recommended, go see your provider. Same with those aged over 65. All influenza brands will be included. So if you have given FluMist to a child, because in New South Wales it is funded, it's not in every other state, that will count. But again, also if someone aged is pregnant, obviously they're not going to be counted in these rules, but that will go through to the air. Individuals will stay overdue until the 31st of January next year, so they'll have all that time to be caught up, and it will come up on their statement that they're overdue, but it will not affect payments for children. It doesn't have any impact on payments, and they will start to send letters from the 1st of June to the 30th of September. So just be prepared for a bit of a run-on. Come 1st of June. Those letters won't go out to everyone on one single day. There'll be a bit of a mail out. So just be prepared that you might start getting phone calls to say, oh, I've just got a letter to say I'm overdue. And that's because they are recommended and they are funded to have that vaccine. That's what, if you're looking for something to read at night, that's what the rules look like. And you can just Google the air due and overdue rules, and that's on the Services Australia website. But in better news, or in good news, finally the air due and overdue rules for pneumococcal for First Nations children has now gone live. It went live yesterday. This is hot off the press. So now the rules for First Nations children for pneumococcal now align with the NIP schedule, so that's that 6-month additional dose. But the changes will only come into effect from yesterday for children turning 6 months of age. And they will display the pneumococcal dose for 6 months will display on their history statement, and if they have it at 6 months, it won't knock off the 12-month dose. So the 12-month dose will still appear on their statement, and it won't have any impacts on their family child benefits if they don't have that 6-month dose. So that decision has been made for now. That could potentially change in the future. And it also won't impact on their up-to-date status if they don't have it. So it's really important to remember that the history statement is just a statement of vaccines. It really should be used in with caution if it's been used as a clinical decision tool. You should really refer to the schedule and the handbook for that information. And they will get a letter if they identify as Aboriginal and Torres Strait Islander on their air, and Medicare, they will get a letter to remind them that that vaccine is due. And this is what it looks like. There's a sample, and you can see it's probably not overly clear, but you can see that they'll be due for that 12-month dose. And that's what the due and overdue rules look like. And there's two lists for pneumococcal. There's for Aboriginal and Torres Strait Islander people, and there's for non-Indigenous Australians as well. So just make sure you're looking at the right one. So we get a lot of questions, and a lot of questions come to me from the PHNs, the public health units, just some of the workarounds and problems that people might have. And some of these fixes haven't gone into the air, but I thought I'd just raise them. So if you're giving nirsevimab and a child, and obviously not all children are now getting it, it's mostly done getting a vaccine in pregnancy, but if you do need to give 2 doses on one day, the air will only accept 1 dose of a vaccine, well, in this case, a monoclonal antibody, on one day. So you just report it once, but you note it in your clinical notes twice. And because it will get rejected by the air, so it just saves a bit of, problems from that end. Twinrix Junior, this problem's been around for a while. I'm not sure, it seems easier to get someone on the moon than fixing it, but anyway, or not on the moon or around the moon. But when you report Twinrix, it does not recognise the Hep B antigen, it only recognises the Hep A antigen, so you can report the Hep B antigen as a generic, so you can click on generic hepatitis B, and then both of those antigens will appear on the immunisation history statement. Proda Air, I'm sure you're all very familiar with this, so I'll just sort of skip through this a little bit, but here's some tips that the Air team wanted me to share. They suggest you don't log in to Proda if you're using Proda online, the HPOS online, using a bookmark. There's often little problems with that the hyperlinks change when you've got extensions, so always just type in the Services Australia login. You do always need to use your own Proda. Remember, Proda is just your personal identity. It's recognising you as a real person and you've gone through that identity check. Always use your own. And whose Proda times out, and it gets very frustrating if you're sitting there entering. So the reason for that, and sort of an alarm rang in my head when they actually explained it to me, was that Proda itself is timing out because all of your activity is happening in HPOS and air. So it's the Proda timing out. So you just kind of need to go back a screen and sort of refresh and come back in again. So I know it's not ideal, but again, this is patient information, identified information, and they want to make sure the right people are looking at the information. So for those who don't have access to the air through the Service Australia through Proda and then HPOS, you can register for an air provider number using the IM004 form. If you're not at a GP practice, you do need to get approval from New South Wales Health, particularly for those working in aged care. I think there was someone here. There is a process for that. And then you can link it to your software, and then you can link it in the back end to Proda and HPOS. But I'll get to a little bit more. That's what the IM004 form looks like, so you can download it from the Services Australia website. It is a bit of a process to set it all up the first time, but there's some really good guides which I'll get to help you work through all of those steps. So remember, you need to, particularly for those who are acting on behalf of and working under an organisation, the organisation needs to be registered. You as an individual create your own Proda account. That stays with you. So for those working in general practice and maybe in a school setting as well, or in a community health setting, you take your Proda account with you wherever you go, and then when you log in, you can act on behalf of different organisations. So that stays with you for life. So if you are registering for the first time, I suggest you use a private sort of Gmail account or something. Don't use a work email because it can stay with you then for your whole career. And then you can also add an authorised staff to act on your behalf, of people the organisation can add you to their organisation, and then when you log in, you're the individual acting on behalf of. So for me, I've got a login via NSIS, and we sit under the Sydney Children's Hospital Network. So when I log in, it's Lauren Dalton on behalf of, so that's what you'll see in the little right-hand corner of the AIR screen. But there are some great resources, and I'll go through some of these in more detail in a little bit, but about how to access the AIR, some infographics, there's e-learning modules, there's something for everyone, whether you like to read, like to view, like to see a simulation, they're all there. And if you're having issues with PRODA, there's some workarounds and some checklists online as well, but there's also some help desks that you can call, and I've got all their contact numbers at the end of the presentation. One thing that happens a lot is about you've entered the wrong vaccine. You put Infanrix Hexone instead of Infanrix IPV or the wrong flu vaccine. You can amend that. You don't need to resubmit, well, and you shouldn't resubmit. You can amend the encounter. So if you were the person who entered it, whether that be in your practice software or on the AIR site, and it's within, before the payment, that monthly payment has been made, if there's a little, when you log back in, if there's a little pencil button, you can go in and edit the encounter. So I'd encourage you to have a look at that. So identify the individual, update it, and that's what it will look like. Don't resend the encounter, because if you do, you'll get append, and then there's 2 encounters in there, and then it gets all very confusing, and someone manually has to go in and fix all of that. So you don't resend the encounter, because it will partially process, and just remember you can't do it if the payment has already been made, if it was given from somewhere elsewhere, and if that's the case, you can send a request to the AIR team via HPOS messaging, which I'll show you in a moment. And there's a nice infographic on that as well. They're not very pretty, but they do the job. If you need to delete a vaccine, so if that 30 days has passed, or if you've just made a mistake or you're not the person who originally submitted it, deleting a vaccine out of your software does not delete it from the register. So what you need to do is you need to notify AIR to delete the encounter and then resubmit the correct encounter. And you can remove it from your practice software as well. So I got an SOS call from the AIR team yesterday that said, can you please talk to the audience, and you're the first to hear this, some communication's about to come out about this, about reporting errors of influenza this year. So flu this year is a bit confusing. There's new vaccines, there's changes to vaccines, there's flu misfunded by the state. Queensland Health, for example, have funded all people aged over 6 months. So there's a lot happening. And what's really important to know that the AIR team, since flu's rolled out, which has been probably not even a month, there's been 15,000 errors reported to the AIR, which is more than the whole season last year. Most of those are incorrect funding type, and that's relating to people particularly, and I'll get to it in a minute, who are receiving fluad, or they're ticking fluad, and if they're under 65, they're not NIP. If they're getting it at that age, they it is not funded for certain age groups, and about 6% are giving the wrong vaccine. What's really important that if you are giving if you are giving a flu vaccine to someone aged between 50 and 64 with certain medical conditions, that only Vaxigroup and Flucelvax is NIP funded for that group, not Fluad. And I know it's confusing because you'll see a picture of the box of Fluad in a minute with the way it's been labelled. So just make sure that you're doing that. If the vaccine has been privately purchased, please select other as the vaccine type. It's not sitting under the NIP. And all these reporting errors do have to be followed up by some poor team at the AIR. So we're really keen to see that fixed. So this is the Fluad box, which I'm sure you've all seen plenty. And you can see there, it is registered for use in people aged over 50, but the little black and white box says it's government funded for 65 years and over only. So just make sure for that age group that they're receiving the right vaccine. To help with that, New South Wales Health have this fantastic set of a toolkit and that outlines with pictures who's eligible for what, so you can download it off their website. You know, if you've got a colour printer, even better, print it off, and of course the basket stickers, which you can get from ordering as well. So just to make sure, because your fridges are probably jam-packed, you're about to get RSV for Arexvy for the older people, so I'm sure that there's a lot to consider in this space. And interesting, last year, the AIR team did a bit of a review of just 1,000, that wasn't all of them, but they looked at 1,000 adult doses that were reported for flu vaccines given to children less than 5 years of age. So 75% of them were the incorrect vaccine reported, but concerningly, 25% of children under the age of 5 got the wrong vaccine. So you've got to remember that the person in front of you, the age that they are that day is what they should be getting and which vaccine they should be given. If they're almost 5, if they're a bigger child for their age, it doesn't matter. If they're 4.5, 4 and 11 months, they get the vaccine that's registered for use in under 5s, and that's really important. And to avoid these kind of reporting errors, you know, and I'm sure you all do this, and I'm sure the reception staff always are checking this, you're citing the Medicare card, confirming the right vaccine for the right age. I've checked the age restrictions within the handbook, and better still, those New South Wales Health resources. Just check your software, because sometimes they might default to what the person before had, which vaccine. You might have an old drop-down list, so just check all those things. And don't resend missing or amended encounters. Use the update encounter or notify AIR. But this is also really good. So I'm not sure, does anyone use AIR reports, the function within the AIR site to look at? Okay. I'll show you some of those in a minute, but there is this thing called the monthly reconciliation report. And what you can do is you can download that, and if a NIP payment hasn't been made, so this is more for the children, if an error has gone through and those kids are just partially processed, and then you'll get a phone call from the parent in a month's time or something like that, you can use this monthly reconciliation report, and it will sort of highlight for you in red what hasn't completely gone through. So it kind of gives you a sort of a cheat list of kids to just check their status and check, why didn't that vaccine go through? Did I select the wrong vaccine? Were they the wrong age? And just fix that up, because then that'll avoid those phone calls to your practice. If you need to contact the AIR, we suggest you do that through the AIR site, through the messaging, because it's all secure. You can put up history statements, you can put in all the Medicare details that you like, because it is a secure platform for that. So just select on the landing page of HPOS, because you can message them about a range of things. AIR is just one of them, and you can put, please amend this vaccine and give the information, and you can attach things as well. And you'll get a notification, and you will also get a notification to the email back to this inbox, but you can also have an alert sent to your own emails to say there's a new message for you in this inbox. So it doesn't seem like AIR reports are used very much. They are really useful because they give an accurate report of who's due and overdue for vaccinations. So if you're using your practice software or Primary Sense data or PenCat to pull out a list of overdue kids or overdue adults or whoever it might be, it might not be the true reflection of their status, because if they've visited another practice or gone to the pharmacy or they're in an aged care facility, you won't have all those records in your software. So you can use the AIR reports, and it's particularly useful if you just want to do a target approach. If you've been sort of tapped on the shoulder and said, this area in particular is concerning, the coverage is dropping, and you can pull out a list of overdue children or adults or any adolescents, and you can restrict it to a different variety of things. So people who have just visited the practice in the last 12 months or an age cohort, there's a whole heap of filters you can use. And once you start using them, you'll find that it is really helpful, and you can link it to a quality improvement activity. So if you're looking for a QI PIP payment and you want to do something, that you can do this to do that. And there is some really good guides about how to do that. And just here's some examples. So if you want to see a list of people who are due or overdue, who have attended your practice for any MBS item number, it doesn't need to be for a vaccine, you can use the 10A report. So there's different reports for different processes. And there's the 42A report, which just gives you a list of COVID and influenza vaccines. So if you're following up that group, particularly now, who are due for a flu vaccine and haven't had it, and if they're aged over 75, haven't had a COVID vaccine for the past, 6 months, then you can get a report. And of course, you can co-administer those vaccines. So there's a whole different variety. And I don't know if there was any pharmacists in the room, but they can use the 43A report, which they can also see the list of patients that they've vaccinated previously. That's what it looks like. So you do have to have a bit of an eye of Excel spreadsheets, but if you've got people in your practice that are good with that, but once you get used to it, this is just an example of a child. You can see in the green box everything that they have had, and in the red box is everything that they're due for. So that's what it looks like. And this is an example of what the 42A flu and COVID vaccine report looks like. And as I said, it shows you people who've had no doses, or you can limit it to people who've had just so many doses in the past sort of 6 to 12 months. This is an example from Wentworth PHN, which is in sort of the Western Sydney area, and they did a primary sense, and they found who uses primary sense? Does anyone use primary sense in general practice? Is the PHN using primary sense? No. What clinical audit tools do you use? PenCat, or anyone use those things? Or just the extractions out of your practice software? So they use this primary sense, which is like a clinical audit tool, and they found it just presented nicer than what the AIR reports looked like. And they found for the numbers of kids that they had overdue, so this is a region with a lot of overdue kids, that they found they pulled out a list and then cross-checked it against the AIR, and then they updated their software. You might not know, but the AIR, as I have shown you, they have some great resources, and this is their gateway. They're putting more and more up all the time. They do send me drafts. I send them out to people to have a look at. So if you've got a suggestion of something you'd like an infographic on or a demonstration on, please let the PHN or the Public Health Unit know, and they can let me know, and I'll talk to the AIR team. I meet with them fortnightly. I'm their favoured customer at the moment, but they are great, and they do take a lot of feedback on board, and we have a great two-way conversation about what's not working or what is working on the ground and what they could look at. So be familiar with that. It's particularly useful for new staff working in immunisations. And these are all the topics that they cover. So they accessing the AIR, submitting to the AIR, and how to use AIR reports. And as I said, there's e-learning modules, there's infographics, there's simulations, and they're very well done. They're short and sharp, and you can pause and all those things as well. And this is my last slide, and if you need help, the AIR team are very helpful and can sort of navigate your ways. So if you need help with the AIR or PROTA or HPOS, there's kind of different phone numbers, but all these slides will be with you, so feel free to ring them. And if anyone's ever got suggestions on or problematic problems, please send them through Michelle or the PHN and the Public Health Unit, and I collate those because I look after all of Australia, and I send them to the AIR, so it's like sort of, if they hear everything a few times, then they take that on board. So thanks again for having me, and happy to take any questions or comments, and I'll be around today for the rest of the day. So thank you. Sorry, I think I went over time.
That's all right. Very good. Thank you so much, Lauren. Essential info. Appreciate it. All right, so please give a big welcome now to Dr. Archana Koirala from NCIS. She'll begin with her first presentation for today, Breathe Easy, Respiratory Vaccine Update. The microphone is all yours, Archana. Yeah, warm welcome. Thank you.
All right, thanks everyone. I'm so excited to be here. It's been such a pleasure, and it's always exciting. And I think I'm due to give you 3 talks in a row. So apologies, no apologies, I guess. My first talk is called Breathe Easy, and it's a respiratory vaccine update. So I'll be talking about flu, RSV, COVID, and pneumococcal disease. And you can see on the program that it goes for an hour. So maybe once we get to COVID, we can just have a mini stretch, and then we can go forward from there. Okay, all right. Well, before I start, I just want to say thank you to Uncle Neil and for having us on Wiradjuri land and really acknowledging that, you know, this is the land of the Wiradjuri people and that it's such a privilege to be teaching and lecturing and discussing on this land. All right, so this is the New South Wales Respiratory Report, and it gets updated around fortnightly, and it gives us a bit of a view on what's happening currently. And you can see at the moment, you know, the respiratory viruses are not doing too badly. There is a little bit of a peak in RSV, but it seems to be plateauing. You can see the middle is flu, and flu's on low at the moment, so that's good. We should get our vaccines in at the moment, and with COVID-19, it's on a plateau as well. So it's around. Okay, so we're going to talk about flu. So this is a graph that shows our flu cases in Australia, all around Australia, between 2022 and 26, and you can see that where is it? 2016. Yes. What's happened to 2016 on there? Has it just disappeared? Oh, right. That's a bit weird. When I put it on, anyway, so 2016 doesn't seem to feature very kind of prominently there, but last year was actually a double peak. So you can see that it peaked in winter, and then there was another peak in the summer season. Okay, and that. Okay, all right, now we have a Slido, but I might do the Slido after the next slide, sorry, okay? So you can see this is New South Wales, and in New South Wales you can see that double peak a bit more clearer. So you can see July, August had that peak, and then there was another peak in December. And you can see there that a large majority of the flu was flu A, but a fair proportion was flu B, and that's why we give a multi-strain vaccine to people, because there are different strains of flu. But you can see in December that it was pretty much flu A, and this was this K clade. So can we do the Slido? It's a bit techy, but I think it's really important because it generated a lot of discussion in December last year, and a lot of worry actually amongst people that were thinking about flu. Good, okay. Well, yep, most of you got the answer right. So it is a genetic clade of flu A. It's an H3N2 virus, and I'll go through what we cover in the flu vaccine. It emerged a while ago, actually, in 2018, but now it's become the dominant flu strain worldwide. And those who chose the second one, you're not totally incorrect, because it did cause a lot of severe flu, and it wasn't because it was really far more severe than other strains, but because perhaps the vaccine that was rolled out didn't cover it as well. Yeah, and so there were these articles going around saying harsh flu season may be driven by new variant, and they take a photo of all the cough syrups that don't work. You know, they should actually have a picture of the vaccines that could have prevented it. All right, So we know that flu causes severe illness. And we also know, why do we immunise children under the age of 5? Because they're more vulnerable to flu. They have an immature immune system. They have smaller airways that can get clogged up. They have an increased likelihood of cerebral irritability. So if you get the flu as a child, you're more likely to get an encephalitic picture versus other ages. And children, in particular those with pre-existing medical conditions, are at higher risk. But we also know that older adults are at the highest risk of dying from flu because of frailty, a phenomenon called immunosenescence. So your immune system ages as with everything else, and so it doesn't react to diseases as strongly as you would if you were a younger person. And altered airways, there might be a lifetime history of smoking or COPD. And so it's really the two ends of life that need to be additionally protected. This is PEDS data. So this is surveillance data from pediatric hospitals. And I really want to emphasize this because you can see blue as kids admitted to hospital with a comorbidity versus purple kids admitted to hospital without a comorbidity. And you can see that even though kids and young adults with comorbidity are at a higher risk of complications, most kids that get admitted to hospital are healthy kids. And this is just a case that I was involved with. So on day 0, he was a healthy 15-year-old boy. He presented to the GP with a sore throat. He had some muscle pain, some joint pain, and was just generally unwell. He was on regular Panadol and Nurofen. He had a respiratory swab. It was negative. On day 3, he presented to the ED with fevers and persistent vomiting. He passed a trial of fluid and was discharged. On day 4, he was back in the ED with ongoing vomiting, abdominal pain, was in metabolic shock, and went into the ICU with acute kidney injury. And then he remained in hospital for 4 months with encephalopathy, and that's why it's really important. The ones that I look after that are most severe in the ICU usually have this encephalopathy. He had severe rhabdomyolysis. He needed dialysis. He had compartment syndrome, profound general weakness, and malnutrition. And then this was a 7-month-old who, on day 0, was seen with upper respiratory symptoms. On day 5, presented to ED with severe work of breathing. On day 6, was transferred to ICU with respiratory failure and bronchiolitis, and needed BiPAP, was admitted to ICU. Fortunately, that child did really well and was discharged after a week in hospital. Okay, so we know that flu is severe, and that's why we vaccinate against it. So when we think about the vaccine, we also want to know how effective was the vaccine in protecting people from illness, from GP visits, from being in hospital, from going to ICU, and from dying. And it changes with flu every year, depending on the chosen strains of the vaccine versus what ends up circulating in the community. So you can see that for last year, it had a 56% effectiveness against general practice visits, so that's pretty good, and around a 50% effectiveness against hospitalisation. And it was really kind of pulled down by the influenza A, because the ones that were chosen, was predicted, didn't match the ones that actually circulated too well. But really, the thing that causes a vast majority of hospitalisation is suboptimal vaccine coverage. Right? So you can see this is produced by NSERS. You can go on the website, you can have a look, and you can see that it's pretty lowish in all age groups, including those where it's free to receive a vaccine. Okay. So this is this year up to the 18th of April, and there's a lot of numbers there, but you can see that New South Wales is lowish compared to other states for the 6 months to 2 years, and in the above 65, it's lowish as well compared to other states. And it's really tough because New South Wales is the most populous state. The other thing I want you to also note in this table is that the table has now been split to additional age groups. Whereas we used to report 6 months to under 5 years, now because of flu mist, and I'll go into that, we've split it into flu mist eligibility groups as well. Okay. So, and I know I showed you that the flu was on a low plateau, but we've already had 6,385 cases in New South Wales to date, and it's black because it's the highest across the country. So, for 2026, we have a trivalent vaccine. And those who came last year had talked about that there was a movement from a quadrivalent to a trivalent. And that's because we've dropped one of the flu B strains, because lo and behold, it's actually disappeared, and it disappeared during the pandemic. You might ask me, why has it taken so long to change it to a trivalent? Well, it takes time for manufacturers to be able to move from a quadrivalent production to a trivalent production. So this year, trivalent. Doesn't matter which vaccine you give, whether it was an egg-based vaccine or a cell-based vaccine, it will all contain 2 flu A's and 1 flu B. And then I get asked, okay, well, you've just told me that the K clade has been rampant. The vaccines might have not covered it as well as it should have. So what about this year, you know? And my answer to that is that in 2025, we had a Croatia H3N2, and so we are changing that. You can see that it has been changed to Singapore in the egg-based and Sydney in the cell-based, which are quite similar. Okay, and that is a response to the cake clade. And you can see, and it's super small, but that how we test the vaccine sometimes is that we'd vaccinate someone, and then we would get the blood from that person, and then we would test it in the lab to say the antibodies that this person produced, will it bind to that virus that is circulating? And then if it does, there's a pre and post. So anything that goes up means that, yes, you're getting antibody binding to that specific strain that you're challenged with. So it'll cover, and this is also a very, very complicated slide, but I like it because of 2 things. One is that Croatia is down below in blue, right? You can see that? And you can see Singapore, Sydney is in yellow, and yellow is closer to orange, which is K. That means it is a closer match to the K clade compared to last year's vaccine. Does that make sense? So now you are all experts in phylogenetic tree interpretation. Okay, all right. So we know that recommendations are different to funding, and Lauren's gone through that as well. So we recommend the flu vaccine to all bar under 6 months of age, right? But there has been no change to the funded groups in the NIP, right? So all Aboriginal and Torres Strait Islander people aged 6 months and over are funded. Children aged 6 months to 5 years, pregnant women, people aged 65 and over, and all individuals aged 6 months and over with medical conditions. So it's the same as last year. And this is the table that ATAGI produces, and there are lots of different versions that you can print for your practice with X's and red and green, you know, to say it's funded. But you can see that there are lots of choice, but only certain are funded, and it's really important to acknowledge that. Now, between 2 to 5 years, you can see that the flu mist is funded in New South Wales. So it's grey, which means that it's not NIP funded. But in New South Wales has decided as a state to fund it for children aged 2 to 5 years. And that's different to other states. Some states are not funding it, and other states like WA might fund it to 12 years of age. So it does differ, and it can be very confusing for the members of the public when they're reading information that's interstate or people that have moved from interstate. Okay, so normally we say 1 dose per year, but there are some indications where we say, no, 2 doses this year, okay? So children aged 6 months to less than 2 years, okay? That's different to last year. What was it last year? 9 for all children, right? So a poor 8-year-old would have to get 2 jabs, right, if they've never had the flu vaccine before. So now if you're a healthy child and you're above the age of 2, only 1 dose, okay? If you're a child with a medical at-risk condition, then it's still that 9 years because we want to optimise their protection. And we know that immunocompromised kids might not respond to the vaccine as well. Why is the change in this data, people might ask? Well, they've done studies where they've realised that really by the age of 5, you've probably had the flu, you know, and so you don't need that 2 doses to prime yourself. Pregnant women. So pregnant women should have it, let's say you get it before you get pregnant, but now it's flu season and you're pregnant, then you might get the 2nd dose. Transplant recipients. So I know there was a comment about bone marrow transplants. So a transplant patient, when I see them as immune naive, right? And so an immune naive and immune vulnerable, right? So it means that the first time that they get the flu vaccine after transplant, they should have 2 doses. And travellers. So if you have a traveller that's deciding to, very fortunate and going skiing in Canada, then you would recommend that they receive a 2nd dose of the Southern Hemisphere vaccine before they travel. And this is because we know that the vaccine effectiveness optimally protects you for 4 to 6 months, okay? So by the time that they're travelling, the protection from the flu vaccine this year is probably not so great. Okay? The other thing I just also wanted to say is that different brands of flu vaccines are interchangeable, okay? So let's say someone who is 3, right? 3-year-old comes in and has the jab initially because received the jab and then realises, and this is a 3-year-old who has a cardiac condition, okay? So receives the jab and then realises, oh, this is my first time that I'm getting the flu vaccine. I realise that that they have a medical at-risk condition. They do need that 2nd dose. You could use FluMist, if the child really didn't tolerate the jab. So you can. Where it comes in for me is actually during vaccine errors. So I get updated, oh, bugger, gave this 18-month-old a FluMist, right? And then I say, okay, just log that as an error, acknowledge it, and give the 2nd dose as a jab. Okay, so now I'm going to talk to you about the live attenuated flu vaccine, FluMist, and we're all really excited about FluMist. Who has administered FluMist this year? Oh, fantastic. Who is excited about FluMist? Yeah, nice, good. Okay, all right. Okay, so FluMist is not new globally, right? It's been used for years in the Northern Hemisphere, since 2003 in the US and 2013 in the UK. It's available here in Australia, registered 2 to under 18 to 17 years. And why I say that is because if you Google FluMist, AstraZeneca, USA, it's actually registered to till 50 years of age in the US. So it's different. It's only for paediatric immunisation in Australia. Okay, I've explained to you that the state is funding free vaccines from 2 to less than 5 years, and other states have different criteria. And in children who are within that registered age group, one of the questions that came up when this vaccine was first being rolled out in the Northern Hemisphere is that, oh, will it increase asthma and wheeze in these children? And there's some really good studies that show in the registered age population, it doesn't. So you can use it for your kids who have recurrent viral-induced wheeze and asthma. How does it work? Well, it's pretty nifty. It mimics real illness, but in a slightly different way, in that you insert it into one nostril, take the thing out in the other nostril, and what it is that it is highly absorbable, right? So it gets absorbed very quickly, and it actually works better in a cooler environment. It's been modified so that it absorbs quicker, but it doesn't retain in a child that's kind of a warmer temperature. So that really limits the spread of the virus of the vaccine from the person receiving it to others. Okay? And mucosal protection. So when you give a jab, it causes your immune system to go, oh my God, let's learn about the vaccine and let's create antibodies. But this also alerts your IgA, which lives in your nose as well, and it protects against that. So how does it work when you compare it to no vaccine and when you compare it to the jab, right? So you can see against no vaccine that it is much, much more effective than not having a vaccine. And then when you compare it to the jab, it's equally as protective. The one benefit of the LAIV or FluMist is that because you're getting this mucosal protection, it actually lasts longer. So whereas a jab will protect someone for around 6 months, the intranasal vaccine will protect the child for approximately 12 months. So that's good, isn't it? Yeah. Okay. What are some of the adverse events following immunisations? Well, they're very minimal. A runny nose, approximately 50 kids will complain of that. A headache, vomiting, muscle aches, and that's quite similar to the jab. You know, you're activating your immune response, and a fever. Okay. Ausvac Safety. Has anyone used Ausvac Safety? I will talk about it a bit later, but it's a website, and it actively, if you get a vaccine, then you get a text message asking you solicited side effects, like did you experience fever or did you experience this or that, right? And then people will answer it, and we put that information pretty much live, like within 2 weeks, to showcase what are the solicited adverse events following immunisations that people are experiencing. So on the website, there will be a dedicated page for LAIV or FluMist into around 2 to 3 weeks. Okay, well, we have another Slido. Okay, which of the following are contraindications to FluMist? So when should you not give it? And you can select more than one. Sorry, because I stand this way, then I kind of always look this way. So these people here too. Great, okay. Well, yeah, you're on the ball. Mild asthma is not a contraindication, and we should not be giving it to kids under the age of 2 years, actually. or 18 years and over, and you should not be giving it to someone with severe immunocompromise. It's also not recommended actually to give it to a child who is living with people with severe immunocompromise. And that's because of a potential theoretical risk of transmission, because it is a live attenuated vaccine. But if you look through the literature, there actually hasn't been any documented transmission. So it's something where if it's inadvertently given, I think you can reassure the family. Usually they say just strict hand washing, maybe not to be like directly looking after the kid for 2 weeks, but that's really, really tough if the person who is immunocompromised is the actual kind of caregiver. But there hasn't been any transmission. Okay, all right, so here it is, aged under 2 years. And why? Because I was a bit baffled in terms of why aren't we giving it to kids under 2 years of age? Well, that's because when they looked at that, and I have a slide next up, it actually increased wheeze in that age group. So it doesn't increase wheeze in children above the age of 2, but it can under 2. Moderate to severe immunocompromise, and taking aspirin. Okay, and that's because there is a theoretical concern of Reye syndrome. So Reye syndrome can occur if you're with the flu virus, and so because this is an attenuated flu virus, there is a theoretical concern, and prior anaphylaxis, obviously. Okay, so this is a slide that discusses why it's only registered for over 2, and you can see on the slide, is there a point? There's no pointer, is there, on this? Okay, the bars are higher in the box, right? So it's the age group by week, so by month, and then like the box lines to 23 months, and you can see the bars are higher than that above 24 months. So in the assessment, it showed that for some reason there was an increased wheeze in those who received the flu mist vaccine versus those who did not, and therefore the company has ensured that it's not registered for registered nor recommended for under 2 years of age. But let's say there is an inadvertent administration, don't repeat the dose. If it is an age group that needs the second dose, give it as an IIV, reassure the parents, but do acknowledge that there might be a risk of a wheeze, and this is up to 42 days following immunisation. Okay. So this is some amazing data that I also wanted to show you, that in the UK, they have a schools program. So just like you guys go out to schools and adolescents receive the HPV vaccine, the DTP vaccine, the meningococcal vaccine, they have a program where primarily they started in a primary school setting. They also now administer it in the high school setting, where they go out and they give flu mist. Right? And they showed that in this pilot study that was done in 2014, that it reduced GP visits by 94% in these kids. It reduced ED presentations by 74%, by hospitalisation in this age group by 93%, and it had an indirect effect to the community as well. So adults, it reduced adult GP visits by 59%. So it goes to show that the transmitters of flu are really primary school and preschool aged children, and so by protecting them, you can actually also protect the community. Ooh, whoops, that was kind of, okay. This is a busy slide, and all I wanted to show you is different parts of England had different programs, and the Republic of Ireland did not have the program, and you can see the bumps are just as high. That's the bottom. The bumps are just as high as the United are higher than the United Kingdom. So in the United Kingdom, they started the program and flu notifications decreased, and the Republic of Ireland didn't, and the flu notifications remained year after year. Okay, so some myths and facts. Will LAIV revert to wild-type flu and cause disease? No reversions have ever been observed, despite over 40 years of trials and millions of doses, right? Shedding of the vaccine viruses causes transmission and illness. Shedding does not equal transmission. So in these kids, if you did a PCR test for up to 2 weeks, it would be positive, right? Because you've given the vaccine, and the vaccine is the virus, and so you might be positive, but that doesn't mean that it transmits. Live vaccines cause serious adverse events. Well, LAIV is well tolerated in the eligible age group, and the adverse events are usually mild. And the myth that LAIV is only effective when the vaccine strains perfectly match circulating strains, and because it actually causes mucosal immunity, it might even have slightly broader immunity compared to the jab. I won't go through this, you'll have this, and it's a comparison of the inactivated versus the live influenza vaccine. There are lots of resources online that you can look at on our website and in the Australian Immunisation Handbook. All right, so that's flu, and now I'm going to talk about RSV. Does anyone have one or two questions on flu? Before we move on? No? All right. We have a Slido. Well, I have a question for you then. Which of the following statements about RSV immunisation funding policy in Australia are correct? Ooh. I think I generated these questions in the middle of the night. You can select more than one. Okay, all right. Well, that is great. So the first three answers are correct. So it just goes to show that having two vaccines with the brand names that sound so similar is just an absolute headache, right? And where one is funded for one age group and the other one's funded for the other age group. So really poor choice by pharma companies. All right. Okay. So, RSV notifications in New South Wales. So, again, this can be found in that respiratory surveillance document that's updated fortnightly. And you can see that the top graph is 0 to 4 years of age, and the bottom graph is all ages. So, I'll talk about the bottom first. You can see 90-year-olds lead at the bottom, because... and then it goes to the 90-year-olds and then the 0 to 4-year-olds. And that's because there aren't many 90-year-olds kind of, to count. But yeah, they have high rate. And then the top is, you can see of the hang on, what was it? Per 100,000. Okay, so and you can see at the bottom that in children, it's really the 1-year-olds and then the 0 to 1-year-olds that have the largest burden of disease. And you can see that the 0 to 1-year-olds are actually lower than 1 to 3-year-olds. And that's really interesting because we're using the RSV program to protect the under 1-year-olds. Okay, infants. So you saw that it was really the infants and the older adults that have the highest burden of disease. You can see here, red is Aboriginal and Torres Strait Islander people, and blue are non-Indigenous people. So both, it's very much an age factor, but Aboriginal and Torres Strait Islander people are overrepresented and have a higher burden. This is hospitalizations, and you can see that there was a pretty significant dip during COVID because most viruses didn't circulate, and then a rampant increase after. RSV also has long-term effects, in particular in children. So you can see that blue is no RSV infection in infancy, and red is RSV infection in infancy, and increases your risk of non-atopic asthma in particular. So just a reminder of the immunisation program. We're protecting infants through passive immunisation, and we're protecting adults through active immunisation. So infants get protection two different ways. One, you jab the mum, so you give the vaccine to the mum, and mum produces the antibodies which get transferred via the placenta to the baby, and the baby is protected for around 6 months of life. Alternatively, if mum hasn't received the vaccine, or the vaccine has been given or has delivered prior to the vaccine effectively producing antibodies, we have nirsevimab, which is a monoclonal antibody that can also protect the infant. With the adults, we have 2 vaccines that can be given to older adults in terms of active immunisations, so they can produce their own antibodies for their own protection. So the new thing, and you all were on the ball, in terms of a single dose of Abrysvo is recommended in each pregnancy. So until last year, we didn't have enough data, and we said, give it in pregnancy. And then immediately I'd get the question, but my patient is pregnant again, you know? And then I'd be like, oh, well, we don't really have data now on that, but now we do. So just like the pertussis-containing vaccine, so Boostrix, we give it every pregnancy, okay? And that's because what we want women to do is we want them to produce as much antibody as they can so they can push it to their fetus and protect baby. And it's really cool, actually, because what happens in a pregnant person's immunity is that by the end of pregnancy, the amount of antibody circulating is higher in baby than mum. So mum will actively push out antibodies to the baby, so the baby's even more protected than the mother is. Yeah, so things that, you know, mums do for their child, right? Yes. Okay. So what has been the impact of this program to infants? Well, you can see the red versus the green bar, and it's all gone down. So, RSV admissions have decreased, in particular in that under 6 months age group that we're targeting the program against. And so this is some really good data to show that in Australia, so this is Australian data, our program has worked. Right? And the estimated effectiveness against hospitalisation for the maternal vaccine and in our setting is around 80%, and the effectiveness of nirsevimab is around 87%. So it's pretty fantastic for the population of Australia. Okay, so RSV in older adults. So you can see this is interim analysis of a colleague of mine in Queensland, and his PhD is on hospitalisation of respiratory viruses, and you can see that from the data gathered that the RSV hospitalisation increases markedly from 50 years onwards. So you can see that from 50, that curve becomes more exponential, and it goes even higher as you grow older. The next figure shows that your risk of death in an older person is compounded if you also have a comorbidity. So if you have things like cardiac disease, immunocompromise, kidney disease, your risk of death is higher, adjusting for age compared to someone without those comorbidities. So age and comorbidity are risk factors. So, so the vaccines were available for older adults on the private market since early 2024. They were pretty expensive, so $300 to $350 per dose, and so there was pretty limited uptake. And you can see the data that ANSIOS has provided, that 3.5% of adults over 75 took it up, and 1.2% of adults aged 60 to 74 years. So, because the burden of RSV we now realise is significant in older people, the government has agreed to fund an RSV vaccine for older Australians. So it commences on the 15th of May for all adults aged 75 years and over, adults aged 60 years and over who have a medical condition that increases the risk, Aboriginal and Torres Strait Islander elders from age 60 onwards. And then the others can, from 60 or even 50 onwards, you can consider the vaccine, but that means you have to pay for it. Okay? So, and it's Arexvy. And, I think Annie taught me some things to remember, and I think I shared them with you last year, but, XVY is like end of the alphabet, right? So think of that. And then I've heard like Abrisvo sounds like embryo or something, and then the B in Abrisvo is for baby, so maybe write it really big or something somewhere. Yeah, because it is so easy to get mixed up. And Arexvy is an adjuvanted vaccine, because like Fluad, we want to make sure that we give that adjuvanted vaccine to older Australians because it can boost that, it can overcome that immunosenescence. And if you give Abrisvo, then they'll have to pay for it. So Arexvy for the XYZ or something, XVY, yeah, okay. There are jurisdictional funded RSV programs that are different to New South Wales, and this is not New South Wales. I just wanted to flag it with you that Western Australia and Victoria have a younger age threshold, and they're state funding it for residents in aged care facilities. Okay, so if they're in those areas, then they have a younger age cutoff. That is not the state. That is not. In New South Wales. Okay, so what about the use of it in adults? And really, the slide you can read it. It shows that it has a pretty good impact, a pretty high impact on RSV hospitalisation reduction. Okay, and Abrisvo works just as well as Arexvy, but it's not funded for older Australians. Okay, and this is just some data from overseas that where they've rolled it out in a population, and it shows that it's actually quite small, 100,000. That it has made a huge difference. And you can see that it's really the huge differences in that age group. So you can see in that last that there's a dip in that age group who are eligible for the vaccine. So again, I touch base about Ausvax safety, and you can get that data. So for the people that are coming in, they might say, but what are the side effects, adverse effects following immunisation? Go to this website and say, look, this is from this year in Australian adults. These are the things that people most commonly complained about, and it's things that you would experience following an immunisation usually. There's also, you might have heard that, discussions over Guillain-Barré syndrome, extremely rare, but there is a slight risk. And what we say is that the risk, so in adults aged 75 years, the risk was 4 times higher in someone who received an immunisation versus someone who didn't. And then that just increases the excess GBS cases by a certain amount. So with Abrisvo, there's potentially an excess number of cases of around 9, and with Arexvy around 6.5. So that's really important to also acknowledge that you are giving a vaccine to prevent against a disease, extremely rare adverse event following immunisation, but there is that slight risk. Okay? And so some key take-home messages. A single dose of RSV will be funded under the NIP for all adults aged 75 years and over, and Aboriginal and Torres Strait Islander adults 60 years and over. RSV vaccines are highly effective, they're safe, and they can receive the same time as other vaccines, because also all the vaccines that I'm talking about can be given concurrently. Okay. And this is a really good table that you'll receive that just shows which ones are funded by what type of funding. And this is just a slide that shows that nirsevimab, which population is nirsevimab recommended for. So what our mainstay of the infant program is to immunise mums, but if the baby is really vulnerable, for example, has a risk of severe respiratory kind of congenital conditions, mum's on immunosuppression, so she might not produce antibodies, then they should also get nirsevimab, or if mum just hasn't received the vaccine, then the baby should be offered nirsevimab, and kids at high risk can get another dose in the second season. This is a slide that is just for your interest, but just to know that there are other products that have been TGA registered. So the mRESVIA, don't really know how to say it. Anyway, it's an mRNA vaccine against RSV, and it is TGA registered. And for adults over 60 years. And what it does is that it works like the COVID vaccine in that the mRNA will produce the protein, that is that F protein, and your immune system will produce antibodies against it. There's also another monoclonal antibody that's been registered as well. It's called Enflosia. And but these are kind of just to note. We'll see what happens next year in terms of product availability. Any questions on RSV? Yes. mRESVIA? I don't know at the moment. I think is it even available? Yeah. It hasn't come to the market. It's just been registered on the TGA. Yeah. I'll have more info probably next year. Yes? Single dose. What medical conditions the persons over 60 years make them eligible to receive the funded RSV vaccine? Yeah, so it's usually so there. If you look on the AIH, there's tables, and the tables are slightly different depending on the flu versus COVID versus that vaccine. But generally, it's for people with lung problems, so like things, and people who are severely immunocompromised. Yeah. Oh yes. Sorry. See, I'm fortunately I have Lauren, and only so it's recommended but not funded. So it's only funded for people 75 and above. So that was a typo in my slide. So did everyone get that? 75 years and above, and 60 years and above in Aboriginal and Torres Strait Islander people. If you're neither that, then you have to pay for it. But I would recommend it because your risk of dying is significantly higher. Okay, everyone ready for COVID? Okay, woohoo! All right. So COVID is now an endemic virus. It's not a. We're not in kind of pandemic mode, but it's here to stay, and it's with us, and it changes just like we change clothes. It changes clothes too. Okay. And the notifications are really on hospitalizations. Not many people are testing otherwise. So, what sub lineages? So it's all Omicron, but now they have all these different letters and numbers, right? And so the respiratory reports create these beautiful pictures that I find, wow, that looks absolutely stunning. And then you have to look at the colors, and then you look at the letters and numbers. So I created this little cartoon that says, so it's BA 3.2, KP 3.1.1, NB 1.8, XFG these days, eh? And then, don't you love a pretty picture, right? So all that shows is that it's changing, right? Lots of different strains are circulating. Okay, but fortunately, despite all that havoc in that painting or figure, things are remaining the same in terms of recommendations. right? So COVID-19 vaccine recommendations and booster intervals remain unchanged. Really, we have the LP 8.1 vaccine, and it's funded for anyone who would like a vaccine. These are the vaccines that are available, so you can see that it's an LP 8.1. And again, because I'm a little bit of a nerdy wordy and I like these serology graphs, so the question that I ask is that, yes, okay, we have LP 8.1, but we have all these other garbled names of strains of viruses that are circulating, and none of them have LP 8.1 on them, right? So what they did is that they gave that LP 8.1 vaccine to people, and then they took blood from them before and after, yeah, to see if they produced the antibodies. And then in the lab, they put that blood next to one of the circulating viruses that we have now, right? And they looked at to see if it bound or neutralized it, right? Does that make sense? Yeah, so it's a way to kind of do a test, not looking at disease, but just looking in the lab. And anything that goes up means that the virus was neutralized, right? So that means that if you give your patient the LP 8.1, it will still work against the other strains that are circulating. Okay? And also, as you know, I do like a pretty picture, and there are so many colors on that graph. Okay. But this is really the take-home message, that COVID-19 boosters protect older adults. And red is if you've received a vaccine more than 12 months ago, and blue is if you've received it within the last 3 months. And you can see that blue is almost half of red. So it really reduces your risk of mortality in 65 years and over if you have received the COVID vaccine in the last 3 months compared to more than a year ago. And so that's why the mainstay of our program is to protect older Australians. So we know that it's still a leading cause of death and hospitalisation in this age group. The vaccines protect your risk of dying, and adults aged 75 years and over will benefit the most from the vaccine. You can also vaccinate with COVID alongside other vaccines. So this is the 2025 booster recommendations. So it's, if you're above 75, get one every 6 months. If you live in an aged care facility, ideally get one every 6 months too. If you're above 60, if you're 65 to 74, get one every year. You can consider it for 6 months, and you can consider it if you're immunocompromised and you're younger as well. Okay? And in children, it's really the older children with severe immunocompromise that is recommended the vaccine. Otherwise, children don't need to be vaccinated against COVID-19. So again, we have lots of resources on our homepage as well. Any questions about COVID? No? Yes? Oh, long COVID, yes. Actually, I didn't create a slide on that. So the question was the research around long COVID. But one of my colleagues at NCERS, Betty Liu, she's doing a lot of work in terms of the vaccine to protect against long COVID. And I emailed her, and she said that there's really good data to suggest that the vaccine protects against long COVID. And that's because most people who have long COVID probably had a pretty nasty bout of COVID. Not all, because sometimes people have very mild illnesses and then they go on to have long COVID. And there really isn't much data in terms of the vaccine to reverse the symptoms of long COVID. For example, you have it and you're like, oh, if I get the vaccine, will I get better? The data's not great around that. But yeah, there is good data to suggest that you can protect yourself from long COVID by getting the vaccine. Yeah. Any other questions? Who liked the pretty pictures? No. Oh, thank you. Okay, pneumococcus. All right, now don't worry. Now this is not a virus, this is a bacteria, but it causes respiratory illnesses as well, and we know that pneumococcal vaccinations is an ever-changing sphere. So this is a busy slide, but it just illustrates that Streptococcus pneumoniae is the bacteria that causes this disease. It's a very fancy bacteria in that you can see on the far right that it's usually a diplococcus, so it hangs out with its buddy. It usually hangs out 2 at a time. And then it has this layer around it, which is a polysaccharide capsule. And I usually teach nursing students and medical students and say that we've evolved as humans to take in sugar, right? Because, I mean, it's not so good nowadays, right? Too much sugar. But evolutionarily, we needed sugar to survive, right? Because if we developed antibodies to bread, then you would be at a loss, right? And so the bacteria has evolved to use sugar as a virulence factor to evade our immune response, right? And that's why it causes a havoc, and that's why we're always worried when things are coated with a sugar capsule. Things like meningococcus is also, Hib is also, right? So anyway, so strep pneumo usually lives in our throat, so that is called colonization. And then if it gets into our body, it can cause invasive disease, most commonly pneumonia, and a lot of the times it follows a viral illness. It can also cause meningitis, again, not uncommon in young kids for meningitis, or people who have had operations to their ear or their brain. And otitis media, because it lives in our throat and your throat's connected to your ear, and it can cause nasty otitis media, in particular in kids. And that's just a picture of a CT head of someone with meningitis. So that meningeal line is up because it's inflamed. You can see that line. And someone with pneumonia. Okay? So the serotype, so when we talk about serotypes and we talk about valence vaccines, the serotype is really pertaining to that sugar coating, right? And so there are over 100 serotypes. And some are just more likely to cause invasive disease. Oh yeah, this is one of my colleagues. He put it to like an M&M, right? It's like a sugar kind of coating, but an M&M is sugar all the way through, yes. Okay. All right. So what is the lay of the land in terms of pneumococcal disease in Australia? So there's been 2,380 notifications in 2024, which was the highest number over the last 20 years. You could say that potentially because of population increase, but also that we were getting non-vaccine covered strains causing invasive disease. And most cases were, again, just like flu, just like RSV, in the older and the very young, okay? And there were certain serotypes that were more prevalent in the different age categories. So this is just a picture to show notification is highest in the young and the older people. And in the between age group, it's usually in people with underlying risk conditions. A lot of them might have an antibody disorder. Okay. So this is that classic graph that everyone shows, that when we started with PCV7, it reduced notifications. We went to 13. It reduced it a bit more, but then things have creeped up, and then we knew that it was probably causing more preschool age kids, so we changed the regimen to ensure that we gave it at 12 months of age instead of 6 months, and that reduced a bit. And then no matter what we did since then, it's been going up. This just also shows that the vaccines really have protected against ear infections in kids too. And this is just a fancy graph, a fancy table to show that a polysaccharide versus a conjugate. So when a conjugate just means that it's linked to a protein. And our body, our immune system thinks protein danger. Like, it's not always like all protein, because you need protein in your diet, right? But protein is generally associated with foreign things that might kill you, right? And so if you give a protein vaccine to someone, their immune system will be more heightened than if you give a sugar, Okay, so that's why we like protein conjugate vaccines versus a polysaccharide sugar vaccine. Okay, a Slido, because I can see people kind of dazing and going out, and you have to listen to me for 2 more talks. I don't know, how are we doing? Whew. All right. Oh yes, you should get this. So it means that additional pneumococcal polysaccharide vaccines are recommended for certain, and remember the word is polysaccharide. I had to reread it as well. While people are answering, and if you could just leave it on, can someone tell me the name of the polysaccharide vaccine? Sorry? 23, yeah? Yeah? Okay, we might stop it there. So that answer was a tricky one. It's actually false. Yes. Oh, yes, I got you with one. No, just joking. That's because it was the question was 4 lines. So there's really good data that suggests that if you put too many lines on a question, it becomes overwhelming. So there is no role for a polysaccharide vaccine in Australian children anymore. So woohoo, that's great. Sorry, what's everyone laughing about? Yeah, because people are voting. Yeah. Oh, yeah. Yeah, good. I'm taking my recommendation up. All right. So, 20 PCV for all children, okay? We've made it easy, and thank goodness, because who hated the pneumococcal schedule? Yes, I hated it. I was so thankful for it, but I hated it, right? And so it's the only vaccine for children aged less than 18 years is 20-valent PCV from the 1st of September last year. So the other one, so the 13-valent and the 23 PPV, which is the polysaccharide vaccine, only ever to be used at this time for people aged 18 and over. But the adult program is under review, so watch this space. I know. It's the thing that keeps giving. Okay. So why did we change it in September? Well, that's because we found that up to 41% of, so hang on, let me have a look again. 20-valent PCV, yeah. So that dark blue is what would be covered with 20 that isn't covered with 15 and 13. So blue and dark blue and purple is things that were not covered with the 13 PCV that could be covered with the 20. So it showed that we could increase coverage by just increasing the valency of the vaccine. And that was the rationale for the change. So this is the schedule. And I had Lauren check it for me so many times. So non-Indigenous children, 3 doses of PCV 20. So it's the same as the 13, we just give the 20 now. Yeah. For Aboriginal and Torres Strait Islander infants, it's 4 doses. Yep, so now the air will remind the family too. And kids with a risk condition, also 4 doses. Things like extreme prematurity, lung conditions, cardiac conditions, immunocompromise. Children and adolescents with a risk condition that's above the age of 1, then when they're diagnosed with that, you give them a PCV 20. And you didn't hear it from me, but if you're in doubt and you're confused, I just give a PCV 20. No, the catch-up people didn't. Close your ears. Okay, yeah, yeah. Because what we want to make sure is that anyone who's vulnerable, so kids under the age of 12 months or kids with a medical risk condition, get that 20-valent conjugate vaccines because we know that protein's better at creating an immune response compared to sugars. Okay, but this is a busy busy table, and it just shows that, fortunately, the pipeline for pneumococcal increased valency vaccine isn't short. It's actually, they're creating more and more and more different types of pneumococcal vaccine. And you can see that I've got the box around 20 and 21. And PCV21 doesn't contain everything that 13 contains. It actually contains a wider valent vaccine that doesn't cover all of 13. And why do I mention that? Well, that's because the PBAC last year in November has recommended that this vaccine potentially be reviewed and may be introduced into the NIP. So it's not rare, you know, there's no announcement, there's nothing, but the PBAC, and you can look it up on the PBAC website to say that, you know, that they have put it forward, okay? So watch this space with PCV21. Okay, and you can see, sorry, it's really small. So blue is PCV21, and it would potentially cover quite a lot of the serotypes that are affecting older adults. And this is far too busy for me to talk about, but it just shows that the immunogenicity is generally quite good compared to previous PCVs, and it's got a good safety profile. So there's lots of resources on pneumococcal vaccines, but really what I want to emphasize is no role for sugar under 18, right? Yeah, for now, and probably for all in time. Thank you. Any questions on pneumococcus? Yes?
Again, with the new schedule, or where do you pick up?
Yeah, so what
With
is
it
the question
changing,
that it's
yeah.
an adult, is it? And they've had the polysaccharide vaccine, and it's been a while. Yeah. Well, for adults, it's still, they should have the 13. They should have the PCV13. If they haven't had that, you give that to them. And then you kind of follow that similar schedule that was previously. They need to have 2 PPVs in their life if they're at risk. If it was just an adult that received it because that was the main, kind of the only vaccine, then I would still give a PCV13. Yeah, is that right, Lauren? Yeah. Yeah. It's all about to change, people. But remember, sugar is bad and protein is good for your immune system. But it's really exciting to have lots of different vaccines available. Sorry. Hello, I'm back again for number 2. All right, this one's a bit shorter, and I'll go through, I won't go through it all in too much detail because most of you already do this so well. All right, so it's what to do when it counts. All right, so I'm just going to go through the definition, just touch base on anaphylaxis and the immunisation stress-related response, and just some really easy case scenarios, or not so easy case scenarios. Okay. So an APHE may or may not be caused by a vaccine. It's any untoward medical occurrence that follows an immunisation. It can be coincidentally associated, so it's vaccine proximate, like you get the vaccine and 2 weeks later you get hit by a car. I mean, that's pretty awful, but it's vaccine proximate, so you could potentially label that as an APHE, right? Commonly very mild, and you guys talk to your consumers and the patients about this, and severe side effects are very rare. Serious APHEs can include anaphylaxis, seizures, and other things, and I'll go through that. So the WHO classifies APHEs into 5 different categories. 1, be associated with the product, and things like a fever, because the vaccine will cause a fever, so that's an APHE. Subcutaneous nodules, so if you give an aluminium adjuvanted vaccine, sometimes it might cause a nodule. A mild rash and fever after MMR, anaphylaxis. It might, and the number 2 is a quality defect related reaction where the quality has been a manufacturing issue. So for example, for those working in 2010, there was an increased report of febrile seizures in infants who were receiving the CSL vaccine. And it was because they found out later after lots of investigation because of a manufacturing issue. Number 3 was an immunisation error. So for example, if you immunise in the wrong part of your shoulder, you might get shoulder-related injury. A subcutaneous nodule as well, if you don't do it as intramuscular, then you might cause a subcutaneous nodule. In other countries, things like injection site abscesses may be a problem. And then the number 4 is immunisation stress-related reaction, and it's things that are arises from stress about immunisation. And who remembers the media reports on the HPV vaccines when it was being rolled out globally, and it caused mass fainting in schools, right? And it's all a bit funny, but it actually caused a lot of fervour and kind of rolling back of some of these programs. And then the coincidental event, like the example that I gave you, or more commonly, a viral illness that a kid picks up whilst getting the vaccine because, he's been exposed to other kids within the GP practice, for example. And autism associated with the MMR, it's not linked. We give the MMR-MMRV at 12 and 18 months, and the diagnosis of autism can only occur after 2 years of age. Okay, so common APHEs, this is common, so pain, headache, systemic symptoms of your immune system, myalgia. There are vaccine-specific APHEs, and you guys know all this. So the BCG vaccine might get an ulcer, and more commonly get an ulcer at the injection site 2 to 6 weeks following immunisation. The MMR, you can get an MMR-like illness around 7 to 10 days following the vaccine. With varicella, similarly, it's also a live vaccine, and sometimes you can get little vesicles in particular around the vaccine site, up to 3 weeks. The DTP, you can get that extensive limb swelling, so injection site reaction. That's more commonly if you've received a DTP, if it's a number 2 DTP shortly after you've received the first one, and it's usually in people who receive catch-up vaccines or adolescents. And Hep B, it's an adjuvanted vaccine, so sometimes you might get a subcutaneous nodule. These two, I really want to highlight the injection site reaction. So a large local reaction. Sometimes, and I know this is not you guys, but sometimes people present to the emergency department and it gets misdiagnosed as cellulitis. And it's not cellulitis, it's just a large local reaction. It's not comfortable, but the treatment isn't antibiotics. It's actually movement of the limb and a cold compress. It looks quite different. Who's seen a large local reaction? Yeah, it's usually kind of red erythematous. The person's really uncomfortable, but it's not that glistening cellulitis-like picture. Okay, and then rash. It might manifest it so many different ways, but an immediate onset rash within 15 minutes is more concerning. Okay. So I'm talking to a group of mainly nurses, so you guys know how to immunise correctly. But SIRVA is what we call shoulder injury related to vaccine administration, and that's usually because the person's been vaccinated too high or outside that deltoid muscle triangle. Okay? And so it's actually been given, unfortunately, into the bursa, the joint or the tendon, and the onset is within hours. It can be quite debilitating with significant shoulder pain, They have reduced active and passive range of movements, but they don't have any neurology. So if you were to examine them, they would still have the same amount of power and no sensation deficit. This is different to something called brachial neuritis, which can also occur if the vaccine was accidentally administered into that brachial plexus. It can also be an immune effect, but that usually causes true weakness and sensory changes. But to minimise this, correct technique is vital. Serious APHEs are those that are life-threatening, require hospitalisation, result in persistent or significant disability incapacity, might be a congenital anomaly or birth defect if the vaccine was given in pregnancy, or it requires intervention to prevent permanent impairment. And I'm not going to go through these. These are slides that you can look up on your own time, but there are serious APHEs that are associated with particular vaccines. An example of these are intussusception with the rotavirus vaccine. That's why we don't give it to children above the age of first dose above the age of 15 weeks. Talked about Guillain-Barré when I talked about the RSV vaccines, myocarditis and TTS with the COVID vaccines, and in particular, when a live vaccine is given to an immunocompromised host, it can cause disseminated disease. And before we had Shingrix, we had Zostavax. And Zostavax is a live attenuated vaccine 14 times more potent than the varicella live vaccine. And we've had 3 to 4 deaths in Australia when it was inadvertently given to an immunocompromised person. But that's no longer in use in Australia for some of them. Okay. Anaphylaxis, it's a systemic hypersensitivity reaction, sudden onset, life-threatening, extremely rare. What happens? Well, you give an antigen or an allergen, like if you have peanut anaphylaxis, and your B cells produce IgE antibodies, which causes havoc around your airway and your blood vessels, and it makes you all the fluid in your blood vessels goes out, and your airways constrict, and that can cause it causes inflammation of your upper airways, and that can cause asphyxia. Signs of anaphylaxis: difficulty, noisy breathing, tongue swelling, or tightness of your throat, wheeze or persistent cough, difficulty talking, hoarse voice, dizziness, collapse, pale and floppy in young children, and abdominal pain and vomiting can be a feature, sometimes just loose motion diarrhea. This is a acronym that one of our nurses uses. Does anyone else know this acronym? It's called RAPID. So rash and mucosa, airway, respiratory, pulse, cardiovascular, investigation, diarrhea, and GI tract. And I thought, oh, that's pretty nice, as an acronym. And this is just a picture of more detail in terms of what it entails. So management and treatment of anaphylaxis: lay the person flat, don't get them to stand or walk. If they're unconscious or pregnant, place in the recovery position. If breathing is difficult, allow them to sit with their legs outstretched. So really common sense things, right? Make sure that you're all trained in administering adrenaline, and you have to be, really. And it's 1 in 1,000 if you're drawing it up. EpiPen, remember, what is it? Blue to the, no. Yeah, that's right. I always forget. Yeah, so it's yellow to the thigh, blue to the sky, and don't do it the other way, because then you self-inject, right? And then you're more anxious. And then I just wanted to flag this, that Neffy. So Neffy is an intranasal adrenaline. It's not PBS approved yet, but you can purchase it. Generally not something that is used in a GP practice or a healthcare setting, but it does protect against anaphylaxis. So perhaps in the years to come, more and more people will have Neffy instead of an EpiPen. So just as an FYI. Okay, so immunisation stress-related response. The acronym is ISRR. Refers to the range of symptoms that may appear in response to the process of being vaccinated. Okay? Contributing factors: age, if you're a teenager, sex. Actually, a lot of adult males also have issues. Yeah, sex, weight, psychological, so coping strengths and preparedness, other vulnerabilities. Social, so if your trust in healthcare, if you're really nervous about healthcare, your peer response, when one person faints, it causes everyone else to faint. And social media. This is far too complicated to look, but it's actually, it has a physiological basis, is what we want to say. It's not just like random. It's actually a trigger causing you to have that fight or flight response, and it's usually kind of the lack of like overwhelming thing, and then you get this physiological effect, and it usually manifests as a faint or a vasovagal syncope. So what do? You yourself remain calm. I think that's really important. Reassurance, positive communication with the patient until the symptoms resolve. Maintain that supine position. And what really works that I've found is that practicing muscle tension, it provides them, so you ask them to squeeze something, you ask them to squeeze your calves, and it provides them a distraction and something to do. And that usually allows that stress to kind of dissipate a little bit and the blood pressure and to kind of come back to normal. And hospitalisation is not required. But this table, and it's too small, but it can be found in the Australian Immunisation Handbook, compares faint versus hypersensitivity. And sometimes it's very difficult to discern immediately, because the symptoms, like a hoarse voice, they might be hyperventilating and suddenly they have a hoarse voice, right? And you don't know if this is just a stress or this is actually stress and then anaphylaxis, or are they experiencing anaphylaxis and then they're getting stressed, you know? So it can be difficult, and you know, if you're worried, then of course you need to follow the anaphylaxis management plan, because that is life-threatening. So I've just got a couple more slides, and it's all case presentations and question. So it's a tricky one. There's lots of things, but if you can put it up, and then I'll read through the scenario. Does it come up? Anyway, a 15-year-old girl becomes anxious before vaccination. Immediately after injection, she appears short of breath, chest tightness, tingling in her fingers and around her mouth. She appears distressed and is breathing rapidly. She says her throat feels tight. Those are her observations. Hopefully you can see them. There is no rash, no swelling, and her chest is clear on auscultation. Is this anaphylaxis or immune stress-related reaction? Oh, yeah. Oh, good. Fantastic. Okay. Cool. Thank you. Yep, thanks. All right. So, why is this tricky? Well, throat tightness and shortness of breath, they could be red flags for anaphylaxis. She was tachycardic and distressed, and it occurred immediately post-injection. So that's really good to know, that things that occur immediately after you've injected it is probably not anaphylaxis. Anaphylaxis requires your immune system to produce, you know, that heightened response, and so usually there's at least a 5-minute delay, you know. So when we say immediate onset as anaphylaxis, it's usually not seconds but minutes, okay? And then clues towards the stress response was that it was normal oxygen saturation. There were no objective airway signs. Perioral tingling, likely due to the hyperventilation, and symptoms improved with reassurance and breathing control. So yes, I agree with the majority of you that this was most likely an immunisation stress-related response. Okay, this is another case. So a 16-year-old boy receives a school-based vaccine. Within 8 to 10 minutes, he reports feeling funny with throat tightness, lightheadedness, and nausea. He looks pale and sweaty. He then develops a faint erythematous rash over the chest and a persistent cough. his observation, so his heart rate's 115, BP 90 on 60, seems to be dropping a little bit. Respiratory rate of 24, saturation's 96, and no wheeze that you can ascertain. Is this anaphylaxis or an immune stress-related reaction? Yep, good, okay. We can close that off. Sorry, yep. So again, why this may be tricky is that he was, pale, dizziness, nausea, could be a vasovagal. The rash was subtle, so it wasn't fulminant urticaria. And there were no obvious wheeze early, but clues, as you all kind of indicated, there was progression of symptoms, there was a respiratory feature, there was hypotension, and potential multi-system involvement. And so this might be anaphylaxis, and we need to make sure that we manage for that. All right. So I just wanted to say that I work at InSwiss. We have a clinic and we have an email. Who has emailed us on the SCHN InSwiss? Oh yeah, your Public Health Unit, yeah. So it's open, so that email is open to all providers. No consumers, but providers. And you can ask us a question if you also have a question. So if you have questions that are better asked to the Public Health Unit, then they're your first port of call. But if it's and the Public Health Unit might forward it to us as well. We have a specialist immunisation clinic, and for the moment it's only in paediatrics, but we also do telehealth. So we do see kids from all over New South Wales and ACT in terms of questions around immunisation, and a lot of the referrals are about APHIS. And we also have the ability to see children who are difficult to immunise, like children who have anxiety issues, who are neurodivergent, and we have a specific clinic. And I just wanted to flag that this year our fellow is Jenny, and then Dee came and chatted with us last year, and they managed most of the emails, and we have a meeting every day. And on the top is all the consultants, and you can see Professor Nick Wood is there as well. Yeah, I know you all love. And that's our clinic room, and you can see in the middle there's a little boy getting the flu mist, and I like that picture because it reflects true life. I watched the AstraZeneca video and I was like, I don't think that kid just smiled through the whole thing, right? But he was a bit uncomfortable with someone approaching him, but then gave a high five immediately after and tolerated that really well. So that's great. So who gets referred to a specialist immunisation clinic? Well, the most common referral are for APHIS, and then for complex medical backgrounds. And of the APHIS, the most commonly we see kids with rash, because I think that's the most common thing that happens, and also things like severe local reaction, seizures, HHE, hypertonic hyperresponsive episodes, and apneas. In terms of our email, we get our most common email that we get is on vaccine error and what to do about it, and we get asked a lot about APHIS. And last year it was on MMR was our most common question on an error, and it might have and JE and usually I don't know why flu's so low, because usually there's quite a lot of questions around flu, and it sounds like there's lots of flu errors this year, according to Lauren. Okay. And that's that. So yeah, that's all on APHIS. Thank you. Okay. Hello, everyone. I'm back again. I heard the last speaker was very great. All right. Well, I'm the last speaker before your lunch, so. All right. So I'm going to just talk a little bit about meningococcal disease. It's rare, rapid, and high risk. All right. So who's heard about the Men-B outbreak in the UK? Yeah? Some of you? Yeah. So there's been an outbreak in 2 jurisdictions in the UK, Kent in March 2016, and I think it was Dorset or somewhere else a little bit more recent. And it occurred in young people. So not infants, but people who are attending university. And it spread really fast. And it was quite shocking in that meningococcal disease is a pretty nasty disease. But fortunately, it's quite rare, right? But in this case, it's spread rapidly. And we think that the spread might be due to the bacteria itself, but also the fact that these places are communal places that a lot of young people hang out and are in close vicinity. Yeah, and then this is in one of the universities, and all the young people are lining up for the meningococcal B vaccine. So yes, there was in Dorset, another outbreak, and then this was just 2 or 3 days ago, just before the weekend. A Perth student, so an Australian, has died overseas with meningococcal B. He was in Europe doing a stint, like a study in Europe, and within hours he actually passed away. So what is invasive meningococcal disease? It's life-threatening, high morbidity. It commonly manifests as septicemia or meningococcemia or meningitis, but you can have joint infections, so septic arthritis. You can have conjunctivitis, endophthalmitis, and that little baby over there, and pneumonias and enteritis, although they're really rare. It's a medical emergency. Unfortunately, the symptoms and the signs in the early stage are quite indistinguishable from viral illnesses in that it's a very kind of like they have a fever, they're unwell, they might have a sore throat, and they might even have a urticarial rash initially before it progresses to a non-blanching rash. A lot of people carry the bacteria in their throat, but only a few get disease. And so the risk factors are smoking, intimate contact, crowded venues, close living quarters. Also, if you have a specific complement in immunodeficiency, and that's really important in terms of who is funded for the meningococcal B vaccine in Australia. And asymptomatic carriers are the major source of transmission, right? And it's usually young people, so young adults that are carriers as well. Okay, there's a Slido. Couldn't escape one. Which meningococcal serotype is most common to cause invasive meningococcal disease in Australia over the past 3 years? Okay, thank you. Yeah, so it's meningococcal B, and you can see blue is B for blue. So the vast majority of meningococcal disease currently is meningococcal B. The first graph shows that it is the very young, so infants and adolescents who are overly represented in terms of burden of disease. And also, this is a bit more old data, but it still holds true, that the rates in Aboriginal and Torres Strait Islander are much, much higher than non-Indigenous children. So this is the NIP-funded ACWI and B vaccination. It's so men B in the Aboriginal and Torres Strait Islander children, and for all ages, for people with specified medical risk. And you can look that up, but it's usually people who have a complement deficiency or an immune, or are taking a medication that reduces your complements, or that they don't have a spleen. Yeah? And then ACWY, it's funded at the 12 months and in adolescents, and of course people with specified medical risk. And I've put bold in specified medical risk because the special risk populations actually differs between ACWI and Men B, which is an absolute headache, right? So one disorder you might get ACWI, not B, and another one you might get B, and not AC. It's like people who have I can't even remember, to be honest, right? So complements, a medication that reduces complements and no functioning spleen. And then for men B, it's also people who are living with HIV, and a couple of other things. Someone on Empaveli, if you're on that. And so really it's just look it up, I don't really know how else to say it, but you just got to look it up, put it there, just make sure. And usually people administering those medications will tell the rheumatologist or the immunologist will tell the patient. I just wanted to also highlight that other states have different programs. So this is Men B, and in Queensland, they will fund an adolescent to get the Men B vaccine in year 10. We don't, right? Same as South Australia, and in the Northern Territory, they get it at 14 years. So things are different in different states. So it's really hard if you're working up in, the border, especially the Queensland border, because if you're there, you get it. If you're in school there, maybe you get it. I don't know what happens. What happens if you live in New South Wales, but you go to school in Queensland? Oh, so they would go, but it's the school-based vaccine. Yeah, sure, they probably won't explain them. Cool. Anyway, things you have to think about. All right, this is, the wording is too heavy, but you can see that unfortunately the coverage of ACWY, which is NIP funded, has also decreased. And it's decreased a lot in Aboriginal youth, and that might be because of school presentation on the day as well. So it's something that we really need to reverse. I also wanted to show that the ACWY vaccine not only protects the youth themselves or the infant themselves, it actually has an ongoing effect to the community. So what it does is that it removes carriage from the throat, and so there's a reduction in spread. Okay? And that there's really good Australian data in particular on B in terms of reduction of disease. But meningococcal B has no impact on carriage rates. So meningococcal B vaccine protects the individual, but doesn't protect the community. It's just the way that the vaccine has been developed. It's a very tricky bacteria, B. And so really to protect an individual, they need to be vaccinated themselves. And there's also lots of research around Men B protecting against gonorrhea. The NT have introduced it not only to protect against B, but also to reduce the risk of gonorrhea. And the data is a bit hit and miss. It says 20 to maybe 40% efficacy. Some additional key points that you can look at, and there are lots of resources. And of course, as I've said, there are lots of information on our website. And before I get booted off, I just wanted to say that on the back table, there's a couple of cards on the AusVac safety, so you can pick that up and then look it up. And there's also a Sky. Who's used Sky before? Has anyone used Sky? Yeah, sharing knowledge about immunisation. It's really good info, and we've just updated it in the last year to include adolescents, and then I think there'll be another update including adults and older adults. So those are really good resources. And I might just leave it at that.
Informative, always. No doubt about that. Well, I like refocus. Yeah, it's a good one. Chance not to have any distractions, but just zone in. Spacious venue. Yeah. Up-to-date info. Inspired, updated energy, yes. So thank you for sharing your feedback. And it's wonderful to see the positive impact that these face-to-face forums continue to have on the immunisation space across our region. So with that, let's settle in for the afternoon. I'd like to welcome our next presentation, next guest. This is very close to my heart because I just had my flu vax yesterday in preparation for a trip to Europe in September. So I'm keen to get a sense of travel ready vaccines for a world on the move. So please give a big welcome to Dr. Annie Huang from NCS, who's going to take us through the world of travel and vaccinations. That's your green button. Yeah, and just point it that way when you press it. As the receiver. So if it doesn't move, you know why.
Okay, all right. Okay, hi everyone. Thanks so much for having me here. It's my first time at this talk, and when we saw the years of service earlier on, I was saying to Art that I am so humbled that people who have worked in the immunisation space for more than 30 years still think that they have something to learn from me. So yeah, hopefully I'll give you some valuable insights today. I'm one of the senior medical officers at NCS. I'm also a GP by background, and I also trained in travel medicine. So to be a member of the International Society of Travel Medicine, you have to sit an exam every 10 years. I last sat my exam 9 years ago, so I'm at the lowest point of my knowledge right now. So, hopefully it's still all up to date. And yeah, it feels a bit strange to be talking about travel medicine at a time of fuel crisis. So these are some tips for you for the next time you go to Penrith, because it's too expensive to drive to Sydney. So I just wanted to firstly also pay respect to elders that we're meeting on as well. Thank you to Uncle Neil for giving his welcome. When we're travelling, we're always thinking about whose lands we are travelling to, so always keep that in mind. So I wanted to start with a question for you. So I'll start off with a Slido. So there we go. Which of these is a travel vaccine? Okay. Excellent. All right. It's still ticking up, so I'm still giving people a chance to answer. All right, maybe we'll stop it here just in the interest of time, but 95% of you gave the answer that I wanted you to give, that most of these vaccines you do have to think about for travel. So it's not just your kind of weird and wonderful vaccines, but also your NIP vaccines and your flu vaccines. Oh, there you go. So this is what I'll be talking to you about today. So I'll tell you a story, give you a few general principles, talk about a few specific diseases, and then a few other things that don't fit into any category. But there's another question for you. So now I'm going to start off with a hypothetical question for you. So you are going on a month-long trip, destination of your choice. There are 4 hypothetical BPDs at your destinations. I'm not naming specific vaccines because I don't want to kind of make people call anyone out for the actual decisions. Each disease can be prevented by a vaccine that's fairly similar. All of them are similar in effectiveness, similar in cost, similar safety profile. So I base these 4 hypothetical diseases on, I don't know if you've heard of the term Delhi belly, where you get diarrhea when you travel to certain parts of India. So I base this on that. So the 4 diseases are Sydney kidney, where you might have severe acute kidney failure, and it's relatively common. Warsaw jaw, where you have, it's painful for you to chew for about 2 or 3 days, very short period of time, fairly uncommon. Then Shanghai thigh, where you might have leg pain for 1 to 2 days, you might have a bit of trouble walking, fairly common. And then my favorite one, because it's the silliest, is Buenos Aires, Iris, where you might have temporary loss of vision, but maybe permanent in some cases, and it's very, very rare. So my question is, which of the 4 diseases would you get a vaccine against? So this is the next Slido. So if you were choosing for yourself, and you could choose more than one, which of the 4 would you, or which ones you can choose more than one? All right. Okay, we might stop it here. I think got quite a few answers. So there's no right or wrong answer here. I can see that most people have chosen Sydney Kinney, the common and severe one, and then the other severe one is Buenos Aires, Iris, so that's the next most common selection, and the transient ones, not as many people picked. And why did there we go. So why did I get you to do this is I wanted to start with getting you to reflect on the fact that we're all human, and that the advice that we give to people in terms of what vaccines to give, we perceive these risks based on our own experiences of travel. So I see this among travel medicine doctors and nurses all the time, that for destinations I've been to, they go, oh yeah, it's safe, you'll be fine. But for destinations that they haven't personally been to, it's like, oh, maybe you should protect yourself against all these other things. So I guess it was just to get you to reflect on what you think about these different types of risks. Something that's common and severe, something that's uncommon and less severe, something that's common but less severe, and something that's uncommon but more severe. So these 4 different categories, just in terms of how you voted for yourself. So now I'll move on to a story. So this is a patient that I actually saw in practice, and it's one of those stories that you couldn't make up if you wanted to, but I just happened to see a patient like that. So this is patient C, who's 35 years old, and I was doing a Saturday morning shift at the clinic. The clinic closed at midday on a Saturday, and he just had to come and see me today. Like he said, he couldn't wait. And so we had known this patient since birth, and we knew that his mum, their family had been patients since at the clinic for a very, very long time. My boss knew him since he was a baby, and we didn't think that he was vaccinated at all because his mum didn't believe in vaccines, but he had a lot of records on paper still, and like when he was a last-minute walk-in, we didn't have time to pull out all his paper records. But we think that he didn't have any other things that we needed to be worried about. And he was traveling to Kashmir the next afternoon. So for those, yeah. So for those of you who know, so Kashmir is beautiful in the Himalayan foothills, and it's in a conflicted area of the world. And he was going there because he had a work colleague from Kashmir who's getting married, and he got invited to a week-long wedding. So he went, yeah, sure, I'll come to your wedding. And it was his first international trip ever. And he was staying at on those lakes on a houseboat. And he was apparently also going to participate in adventure water sports on the lakes. And he was very uninformed. He didn't know where Kashmir was. I knew a lot more about Kashmir than he did. He managed to get a visa. He got his visa just 2 days ago, didn't have travel insurance, didn't actually know that he had to pay for travel vaccines because he's never been vaccinated. He has no experience with vaccines. So he's like, oh, but I already spent all my money for the trip. So this was kind of me, going, oh my God, this is a walk-in patient. There are all of these things that I need to talk to him about. This is just a trimmed down list of vaccination-related issues and all these other related issues that I won't read out right now, but just to say that these are all these things going through my mind. In terms of vaccination-related issues, I was thinking he's probably completely unvaccinated. Also, he's very uninformed about vaccines, and he got more and more scared as we were talking. He's like, oh, I only have one vaccine today. I'm not going to have any more. And I didn't have time to really talk him into any more because we were just so rushed for time. But I also thought, look, if he has a good experience now, then maybe after he comes back from the trip, we could catch him up on all of these other things that he's missed in life if, we would just get him one vaccine into him this time around. Obviously, lots of practical considerations. He's departing in just over 24 hours. The pharmacy down the road's pretty small. We didn't really have that many vaccines in our clinic fridge either. He didn't really want to pay, and I doubt that he had the motivation to go to any extra effort to get vaccinated anywhere else. So my question to you is, so we've got one vaccine to give him. What is the one vaccine you would give him? And this is a very, very difficult question. When I pose this to other clinicians, there's lots of debate, so don't worry about this answer. All right, I might stop it here as well. So I'll tell you, so these are all vaccines that I would potentially consider for him, but I'll tell you what happened at the end after I've gone through some of these vaccines. So just keep your answer in mind. Now I'll go to just a general approach to travel vaccination. So what patients think I do is that they think that I have a magic map and I just look up the country, I go, you're going to this country, this is the list of vaccines that you need. What my colleagues who refer to me sometimes think that I do is that I can magically predict that your patient will be bitten by exactly 14 mosquitoes and one of them will carry dengue. So they think that I have this travel medicine magic. But in reality, I think about the risk in terms of, so you've seen many different triangles in medicine, and this is another one, where I kind of think about it in terms of patient factors, destination factors, and activity factors in terms of the risk. I also, so this is a diagram made by a colleague of mine, Dr. Sarah McGuinness, and so also think about it in terms of investment, in that those vaccines in that green box up there, they're the vaccines that actually have a very long duration of protection. And so you might also think about the sort of patients that travel a lot or patients that have ongoing risk, and maybe if you want to vaccinate them now, it might protect them over a period of time, might protect them for all future trips. So if you have someone in front of you who just travels a lot, then maybe you just think about these vaccines as something that you just need to give once, and then you don't have to think about it in the future. So now go through the patient, destination, and activity factors. So in terms of patient factors, so your standard age, sex, medical history, vaccination history, occupation, so bearing in mind that investment idea that sometimes, back in Australia, they might work in a high-risk occupation for a particular disease. So if you vaccinate them against something when they go overseas, it might also protect them for their jobs in Australia. Past travel, I guess, in the sense of their vaccination history, but also gives you a sense of how risk-taking, their risk-taking behaviours gives you a sense of, their experience as a traveller as well. Who else is travelling is an interesting one, because sometimes you get kind of mum bringing in, this is child A who's 2 years old, child B who's 3 years old, we're going to Indonesia, which vaccines do we need? And I kind of go, but mum, are you travelling as well? You also need vaccines. So sometimes that gets forgotten. Also, there are these special patients, your typical high-risk groups that you see over and over again. Make sure, but also just remember that people don't always travel for leisure. They also can travel for high-risk occupations as well, and just to think about them. And I should have kind of put volunteers there as a special category, because sometimes when people are traveling for an actual Doctors Without Borders deployment or military deployment, they have a special travel medicine service that looks after them. But it's actually like your kind of medical students on electives, or people who go on wonderful volunteering expeditions, who might not have thought through all these things and who might not have access to travel medicine providers. Then your destination factors. So we get this a lot in our NSWIS inbox, and I want to say, look, we are not living in the United States. We have better geography skills. Africa is not a country. Please take a more detailed travel, please ask for a more detailed itinerary. So, think about cities and regions, but also any particularly specific high-risk spots, like are they traveling to a monkey temple, for example? How long are they staying for? So that's important, because sometimes they may travel to somewhere that's a little bit high risk, but only overnight, and then you may be less inclined to offer them a vaccine. The season, so wet season, dry season, has an impact, for example, on mosquito activity, on waterborne diseases, urban or rural. Remoteness and access to healthcare is what I've bolded, because sometimes, you might go to, say you go to this hypothetical island that potentially has no diseases, but if there's only one ferry off the island once a week and you get meningitis, you want to protect that person against meningococcal. And also the likelihood of detours or unplanned side trips. So, you talk to return travellers who went, oh yeah, we were just walking around the city, but then we walked past a really interesting travel agency that was offering an exciting jungle expedition. So we just went on a spur-of-the-moment jungle trip. So bear in mind that these things do happen when you travel. And then there are special destinations. So airplanes, like long flights, are a destination of their own. And then cruise ships, farms, wilderness areas, healthcare facilities. Then activity factors, so thinking about eating and drinking, the yoga retreats with entirely raw foods, maybe not such a good idea in certain countries. Where are they staying? What kind of transport are they taking? If they're going on an organised tour, then they have maybe limited freedom in choosing what activities they do or don't do, or the location they visit. VFR is a term that comes up very often in travel medicine, visiting friends and relatives, and it's actually particularly high risk because people don't tend to come and see a doctor before they go and travel to visit friends and relatives, they just go, well, I'm just going home, I'm just going to stay with my aunt. Why do I need to see a travel doctor, to go on for a travel appointment? Also, quite often you're in a condition where family members are cooking for you or doing things with your family members, and you probably don't have as much choice. You can't just go out to, you're not necessarily going to a restaurant where you can order the safer foods. And sometimes people forget that when they leave a particular country in their childhood, and they live in another country for 20, 30 years, they've probably lost all that immunity, and so they're actually at a lot higher risk of getting certain diseases when they go back. Special activities, so action, adventure sports, mass gatherings, pilgrimages. I don't know why that got cut off a little bit in that slide. But yeah, pilgrimages is an entirely, it's actually one of my favorite topics in travel medicine. Unfortunately, don't have time to go through that today, but that presents its own special risks. Humanitarian work. People who travel overseas for medical or cosmetic procedures, they're at certain risks. And also sex tourism, which is very difficult to get out of in their history. They don't tend to tell them that's part of their plans. Then there are also other VPD-related discussions. So remember that vaccines aren't the only way to protect against a VPD. So make sure that you also talk to people about safe eating and drinking, how to avoid mosquito bites, being really careful around animals. Road safety, if you don't quite get how that ties into VPDs, I'll talk about that later. But also just in terms of making sure that people know how to seek medical care when they're overseas as well. So now I'll go into NIP vaccines. And I've just got a few diseases to talk to you about, and I've structured these slides so that I've got sort of Australia on one side of the international flight, and then we've got the international context. And these slides are wordy, and I'm not going to read all of it out. It's just to kind of leave these all with you, and you can look through them at a later time. But I just wanted to point out that quite often why we vaccinate someone against a disease in Australia might be a little bit different from why they might need to be protected against that disease in an international context. So, for example, diphtheria, up until very recently, up until sort of late last year, we didn't really have much diphtheria in Australia, and that's recently changed. But internationally, there are actually several outbreaks happening, including a huge one in sub-Saharan Africa, where in the last 3 years, 2,000 people have died of diphtheria. And there is a global shortage of diphtheria antitoxin. Diphtheria antitoxin is still made by horses. So you're used to being able to tell horses to go faster, but horse immune systems don't go any faster. They can't make antibodies any faster. So our global supply relies on how many horses we have to make antibodies. So that's why it's important to protect your travellers against diphtheria. Flu, so we've already mentioned flu a little bit, so I won't touch on that too much. Again, just to remind people that you can give a second dose of a flu vaccine in the same flu season if someone is travelling at the end of the year. But also want to remind people that it's not just northern versus southern hemisphere, that when you're travelling to like sort of the more tropical areas of the world, it's flu season year round, so don't forget that. And this is a diagram that comes up very often in travel medicine and gets updated all the time because the risks change. Basically, it's a diagram of the risks of getting various infectious diseases when you're traveling. So the latest update is from 2023. So this is a 2023 diagram. And the higher up it is on this diagram, the higher the risk it is. So you can see that flu is very, very common. And it's one of those things that people don't remember for travel, that it's just because it's so basic that to remember just to vaccinate people against flu before an international trip. So now, and you'll get those diagrams, so you can kind of study that slide at your leisure. So hepatitis B now. So internationally, why we want to vaccinate travellers against hepatitis B. So these 4 groups are things that people think of immediately. So they think, oh, you know, if people are going overseas for a medical procedure, or, you know, if they may be getting a tattoo or piercing. If there's any intravenous drug use, if they're going overseas, you know, to participate in mass parties or music festivals potentially. Sex tourism, again, humanitarian workers or workers who are travelling to work in a healthcare facility. But the one thing that people often forget, and I wanted to point this out, is action adventure sports, and this also ties in with the road safety that I was mentioning before, that in 83% of low middle income countries and 76% of low income countries, they don't follow the WHO guidance for screening for blood products. So you don't want to be in a situation where you might need a blood transfusion, which is where action adventure sports or road safety comes in. You don't want to get Hep B from a blood transfusion in these countries. So you really do want to make sure that these travellers are vaccinated against Hep B. Then measles, which, you know, everyone's been hearing about in the context of international travel recently. I just wanted to point out a very recent practice change. It's been updated in the handbook, and not everyone may have noticed that. So this is about who can get a measles vaccine early, so earlier than 12 months of age. So previously, it was infants travelling from 6 months of age to a high-risk country. Now it's changed to just infants travelling overseas, and you don't have to work out whether or not they're travelling to a high-risk country or not. If they are travelling overseas, you can consider, this is a conversation you have with the parents, giving them a vaccine from 6 months of age onwards. And this is because you can see that in 2025, the latest stats just came out that measles was actually reported from 180 out of 194 WHO member states. So really measles is everywhere. So you don't have to really think about which countries are at highest risk anymore. But do remember that if you give someone that first dose of measles before 11 months of age, that you do need to repeat that dose once they reach 12 months of age. So make sure that when they come back, that you do still give their 12-month dose and then their 18-month dose of MMRV. So it's an extra dose that you are giving them. So now moving on to meningococcal. So we've heard about meningococcal in Australia, thanks to Arch. But just to talk to you about international travel. So every year, 32,000 people die of meningococcal around the world. And the cases are actually increasing in most countries after COVID. You might have heard of this term meningitis belt. So this is the area, this kind of area across the middle of Africa where the risk of meningitis is the highest. And it had always been meningococcal A, but now with better vaccination, it's actually more and more meningococcal Y as well. And so now it's ACWY for that region. For certain pilgrimages, mass gatherings, you can... I don't know why all my pilgrimage words got cut off in the slides. I don't know, but you actually need to demonstrate evidence of ACWY vaccination to get the visa. One thing that I want to remind people about, so we all think about meningococcal in the context of military, in the context of, university, dormitory settings, but don't forget the people on working holidays, backpackers on working holidays. So they may be outdoors all day picking fruit or doing whatever, but at night time they're often sort of sleeping in quite crowded conditions, and then they're at that age group where the risk of meningococcal is quite high. So don't forget them. And then, as I said, remote locations, difficult access to healthcare. Remember, you don't want to be in a remote location where if you get meningococcal, you can't get to healthcare straight away. Then polio, as many of you know, we've eliminated polio in Australia, but globally it's still classified as a public health emergency of international concern. It's the longest running public health emergency globally. And among our neighbouring countries, we've had some recent detections, so PNG and also in Laos in the last couple of years. Then tetanus, just to remind you, of course, that travellers are at a higher risk of injury. You're jet lagged, you're tired, you're in new surroundings, you're performing new activities. I mean, in a country, you can probably empathise with this yourself, that in some countries that you travel to, even when you go upstairs, the steps are built for people with a slightly different leg length to you, and it's so much easier to trip over, to bump yourself on things when you're travelling. So make sure that your travellers are up to date with their tetanus shots. And there's also this huge global shortage. It's intermittent, so every now and then you get a big global shortage of tetanus immunoglobulin as well. So you don't want to be sending unvaccinated travellers out there who might need immunoglobulin. And then finally, COVID. I know it's not NIP, but I've stuck it into an NIP slide just to say that, even though even the WHO says the global burden of severe COVID has declined, you still want to think about high-risk settings, and there are still new variants, as Arch mentioned before. And so, if someone is travelling, you probably do want to just ask about when their last booster was, and just make sure they're up to date with their booster. So those are the NIP vaccines. And so now I'm going to move on to the more exotic vaccines. And so I've structured these slides slightly differently as well. So I've got the products up the top, and it's very, very small print. You'll get those slides, but it's basically the age groups that you typically, the vaccines are licensed from. So green is when the vaccines are licensed, and the reddish orange are when you shouldn't, the age groups where you shouldn't be giving the vaccine. So for cholera, I've just listed a few patient destination activity factors. I must say that cholera vaccines are not actually that effective. So I'm personally somewhat reluctant to give the cholera vaccine unless they do have a high-risk comorbidity, unless they are going to a humanitarian setting. So I usually wouldn't offer the cholera vaccine. Because it's really a lot more important to educate on safe eating and drinking in general when you're travelling. And that protects you against a lot more diseases than just cholera itself. Hepatitis A. Hepatitis A is one of the long-term investments that I was talking to you about before. There are lots of Hep A products, including the Hep A/B Twinrix product. There's also Twinrix Junior, but I haven't seen that around for ages and ages, so I haven't included that. So these are vaccines that I've seen around. So my main consideration for Hep A, firstly, is that kind of long-term investment, but basically, I consider these destination factors. So the moderately to highly endemic countries really could be any lower or middle income country. So it's a really effective vaccine, and it's fairly safe. So I usually do say, look, just get your Hep A vaccine and then get another dose when you come back in about 1 to 3 years' time, and then you're protected for life. You don't have to think about it anymore. So again, remember to educate on safe eating and drinking. Japanese encephalitis, which has a special place in this region. I said in the box below that Imojev can be given intradermally in times of vaccine shortage, and it's with thanks to the people of Western New South Wales. I don't know how many of you knew about the clinical trial that NCS ran a few years ago about whether or not Imujev can be given intradermally as well as subcutaneously. So our participants in Western New South Wales helped us answer that question, and so that advice has now become ATAGI advice, that you can give Imujev intradermally in the setting of vaccine shortage. So Japanese encephalitis is one of those things where it's got this huge grey area about, should you give it or should you not? Well, what counts as a... So, the official advice is give it to someone who's travelling to a rural area for an extended period of time, but what counts as an extended period of time? What counts as rural? And it's one of those things where it is a conversation that you have with your patients. Usually, I'd kind of consider more if you're going to be in a rural area for more than a month, or if you are doing a particularly high-risk activity, like you are going to be near a piggery or something, or you're near water birds, for example. There's a whole yellow area highlighted in the diagram up the top, and that's so the ATAGI recommendation is that you can potentially give Gespec to people in that age group if they can't get Imujev for whatever reason, or in the younger group where it's you can't get Imujev if they're really travelling to somewhere high risk. Mpox is always something to consider. I know that not all GPs can give them, so you might have to send them somewhere else to get the Mpox vaccine. But remember that there are high-risk patients, destinations and activities, so that might make you think about Mpox vaccines. And now rabies. So Victor, you've heard about rabies from Victor this morning, and he did say that I will talk to you a little bit more about pre-exposure prophylaxis. So I've got the patient factors there that quite often you worry a lot more about the young children, ambulant children who are running around, who might be patting animals. Also because the incubation period of rabies varies a lot with how far away from the brain you are bitten. And children are a lot shorter. They tend to be bitten on the face, so they get a lot more facial upper limb bites as well. And so those are higher risk bites. Also people who are newly arrived at a destination who might kind of be situationally unaware, they might accidentally be bitten. But I've also listed what I've called the unpatient factors. So these are the kind of protective factors, if you will. So we found among the travel medicine world that people rarely need post-exposure prophylaxis twice. Usually if you've been bitten once and you've gone through the traumatic process of going to get a rabies post-exposure prophylaxis vaccine, you are super careful around animals and you don't get bitten again. So that just tells you that if you can make people take care around animals, if you can really just educate people to avoid being bitten by in the first place, you just avoid a lot of this stress. And apparently, they did a survey of travel medicine providers, and only one person has ever had an animal bite that needed post-exposure prophylaxis. It might be because there's also social desirability bias, that people didn't want to answer yes on the survey when they're a travel medicine provider. But usually when people are experienced in travel medicine, they really are really aware of the risks of animals, and it's really in the bite avoidance is something that we stress people over and over again. Destination factors, obviously the monkey temples and forests, but also think about access to rabies immunoglobulin as well. And in many parts of the world, if you get a high-risk bite and you need immunoglobulin, you can't access it. In Victor's slides, he uses the acronym HRIG, so human rabies immunoglobulin. In most parts of the world, it's actually ERIG, equine rabies immunoglobulin, so from horses again, because human rabies immunoglobulin is a lot less available globally, and quite often in many parts of the world that they rely on equine rabies immunoglobulin, which, as you can imagine, you need a much bigger dose, and it is maybe a little bit less effective than the human product. So also think about that kind of availability in terms of your destination considerations. And just to reiterate what Victor said, that if you get pre-exposure prophylaxis against rabies, it means that if you do get bitten, you don't need the immunoglobulin, and it also simplifies your post-exposure prophylaxis. Now, one thing that we have now realized in the travel medicine community that we haven't told everyone yet, because we still want to just make sure that this is right first, is that we've done a review of everyone who's had rabies in the last few decades. And so nobody who has had pre-exposure prophylaxis has ever actually gone on to develop rabies, regardless of whether or not they could access post-exposure prophylaxis in time. So there is this kind of broader question of, in the future, whether or not people who have had their pre-exposure prophylaxis will actually need post-exposure prophylaxis. But that's a question for the future. We haven't decided on that yet, so please still keep giving people post-exposure prophylaxis, but just to let you know that this is why pre-exposure prophylaxis is so important. And this is a diagram that I made a few years ago, and so I keep trotting it out because I'm proud of it. So these are the schedules that are in the handbook. So we've always had this 3-dose schedule, but in the last few years, we've said, look, if you've got a traveller who's departing soon, there's also this alternate 2-dose schedule where if you do then after they come back offer them that 3rd dose at about 1 year, and then it gives them a longer term protection. And then there's intradermal schedules as well for people who are comfortable giving vaccines intradermally as well. I've just put just a couple of notes on post-exposure prophylaxis, because I knew that Victor was going to talk about this. My biggest point about this is if someone had a rabies exposure overseas and now they're coming to you to follow up, make sure you contact the public health unit. They will give you the advice you need, and they'll also help you access the products that you need. So don't try to manage this alone as a GP or in a primary healthcare setting. Also ask about, so if they said, oh, I got the rabies vaccine overseas, I already got my 1st or 2nd dose of rabies vaccines overseas and then I flew home, ask them about where on their body they got their rabies vaccine. So our colleagues at the Pasteur Institute in France, they did a little bit of an audit of their cases, and they found that 10% of people inappropriately got a rabies vaccine in their bottom. So you're not meant to give the rabies vaccine in the buttocks. So it says in the handbook, no intragluteal IM administration of rabies vaccines. So if they actually got the rabies vaccine in their bottom, it means that you actually do have to repeat that course. So those doses don't count, you have to repeat. So make sure when you take that history, where did you get your rabies vaccine is an important question to ask. And then also, if they said, oh, I also got immunoglobulin overseas, see if you can find out whether or not they got human or equine immunoglobulin. Then TB, BCG, I know that you have to get these at chest clinics or at specialised settings, so you have to refer people. Just to say that BCG, so it's only the very youngest age group that I've coloured green. The older age groups I've coloured yellow because there are special cases where you're a healthcare worker, where you can potentially still have a BCG vaccine. So rabies. The BCG vaccine is really to protect our youngest children against complications of BCG. Because maps and things change all the time, I've just put links in the slides for you to check out. But just to say that it's like when people are visiting friends and relatives, that's when they're at highest risk because they might be living with so many family members, some of whom may actually have latent TB that they don't even know about. And, you know, like babies get passed around, get kissed by all the family members, close contact by lots of family, with lots of family members. Then moving on to typhoid. So this is the typhoid map where the more colourful bits are the highest risk bits. So Arch has many stories of patients returning from Pakistan and India who potentially have antibiotic resistant strains of typhoid. So to make sure that people who are visiting friends and relatives, especially going to the subcontinent, get their typhoid vaccines before travel. And I think that's really all I need to say. There is a newer typhoid conjugate vaccine that's actually better than the existing vaccines that we have in Australia, but it's only actually available in 12 countries overseas at the moment, so not in Australia. So if someone is particularly worried about getting typhoid and they're traveling to one of these high-risk countries, you may kind of think about getting them to get their typhoid conjugate vaccine overseas, but in reality, not many people will think of doing that when they go overseas. I wanted to talk about yellow fever. Yellow fever is something that fills up travel medicine, provider discussion forums. It's a headache for so many people who provide yellow fever vaccines. So I want to point out that there are two kind of types of destinations where you might think about yellow fever. So that's why I've got two destination factors box. The first one on the left are your destinations where you need a yellow fever vaccine because of legal requirements, because the country requires you to have proof of vaccine when you enter the country. And there are different lists, like different countries have a slightly different policy. So that's why I can't kind of just give you a list. There are different lists to check. And the US CDC is always a good place to check for that. I guess one thing that I want to also point out is that sometimes it's parts of countries that are at higher risk as well. So you may find that when you go to a particular country, if you fly in to the airport, the air border has a slightly different rule to a land border where you travel in from the next country overland. And it's actually also really highly dependent, unfortunately, on the immigration official. So quite often you actually send people overseas with all the letters that you like, but it ends up being the person actually at the border who makes that decision, and it can be very variable. So it's one of those things that you kind of just have to warn travellers about. Then the second list of destinations are so that middle box are actually destinations where you are at high risk of getting yellow fever. So this is an actual epidemiological risk of getting yellow fever. And this doesn't always match the countries where you are required by law to get a yellow fever vaccine. There's some overlap, but it's not complete. So it is also an international requirement that you get your yellow fever vaccine from an accredited provider, and then you get given this little yellow book. My tip is that that yellow book is paper-based, and it gets damaged in the rain, it gets lost. So make sure that you also copy everything from a yellow book onto the air as well, so you actually have a more durable kind of proof that your traveller has been vaccinated against these travel vaccines. So I also want to talk about patient factors. So there are people who are more vulnerable to getting yellow fever, but then there's also a list of people who are more at risk of getting adverse events from the yellow fever vaccine. So yellow fever vaccine has its own unique APHE that we haven't seen with any other vaccine. So this is yellow fever associated neurotropic disease and yellow fever vaccine associated visceral tropic disease, so YFAND and YFAVD, and they can actually potentially be fatal. And this is why we don't vaccinate babies under 9 months of age. And it's why we are also a little bit wary of vaccinating people above 60 years of age, because they are at higher risk of developing these very severe adverse events. It is a live vaccine, so we also don't vaccinate people who are immunocompromised or pregnant or breastfeeding as well. So this is where this kind of destination legal requirement versus epidemiological risk-based requirement gets really confusing. So when you think about the destinations, you have to think about this Venn diagram of there are places where you only need a yellow fever vaccine because of legal requirements, and that's the yellow bit of the Venn diagram. Then there are places where you only need a yellow fever vaccine because you're genuinely at high risk of getting yellow fever at those destinations, so that's the greenish bit. And then there are places where you need a yellow fever vaccine for both, because you need it for both the legal requirement and also because of yellow fever risk. So for people who are only needing the yellow fever vaccine because they have a legal requirement to get a yellow fever vaccine, not because of anything else, it's just for paperwork. If they belong to one of these higher risk groups of getting an adverse event, then what we'd basically do is give them a waiver and say, well, they're at higher risk of getting an adverse event from the yellow fever vaccine. We consider that they have a medical contraindication, that they're waived from getting a yellow fever vaccine, and that kind of gets them through that legal requirement. But if they are at that high risk group of getting yellow fever and they're traveling to they're in the high-risk group of getting yellow fever vaccine APHE, and they're traveling to somewhere where they're also at high risk of getting yellow fever, then you have a trickier situation where quite often you have to go, well, do you have to go to those two particular cities in your itinerary? Can you change things? Can you shorten your length of stay? So you may actually have to counsel people about their risks, and then it becomes this kind of risk-benefit discussion. One of the things that I tell people is that if people... You see how the older adults above 60 years is a precaution. I tell people that if you're planning to be a grey nomad one day, and if you're planning to go to some of these countries, just get your yellow fever vaccine before you turn 60, and then you don't have to think about all of these extra risk factors. So that's yellow fever. And now there are these very, very exotic vaccines, which I only have one slide for. And so that's the vaccines outside of TGA registration. So you can potentially get all of these other vaccines, but you have to get them through special access schemes. So if you are considering getting these vaccines for patients, it's probably a good idea to refer them to someone who's specialised in travel medicine, and they can talk about the risks and benefits, and they have ways to access these vaccines so that saves you from figuring that out yourself. So I've put TB and typhoid there because technically they aren't registered in Australia, and we actually give the TB vaccine in our kind of chest clinics through that special access scheme. Then there are other vaccines like the Ebola vaccine that's actually in this global WHO stockpile that as a civilian you just cannot access. So unfortunately that's a no to the Ebola vaccine. So I've got 5 minutes just for the conclusion. So what happened with patient C? So you remember that story that I told you earlier. So it didn't tell you that actually happened in 2017, so that was pre-COVID. And so we actually did go with a dose of DT. So most of you actually agreed with what we did, but like I said, there wasn't a good answer. And in the end, it was really because he was more accepting of the fact that he's seen his mates get tetanus vaccines after they've had various injuries. So he was more used to the idea of getting a tetanus shot, and so he could be talked into getting that, and that was readily available in our clinic fridge, obviously. But it was quite anticlimactic because he actually just, apparently he went on his trip and came back. Various clinic staff saw him at the local supermarket. But he didn't come back to his clinic for any catch-up vaccine, so I didn't actually get to see him again. So that was an anticlimax. So finally, just some resources and a reminder to take a good travel history or itinerary. And just to really consider these behaviours that you can change. So it's not just vaccines, it's also what people do when they travel. Remember to check that people are up to date with the NIP vaccines and enter the travel vaccines into the air. I know that it's not a legal requirement to enter many of the travel vaccines into the air, but it is super, super useful because people don't remember what they had on their last trip 20 years ago. And so it's really good to have that all documented. With resources, I want to say that one question that I often get asked is, as someone who does travel medicine, what map do you use? And it's actually a really tricky question for me, because for me, I know most of the common destinations, so I wouldn't be looking up the common destinations on a map. And so for me, it's when I have a specific question, and it depends on the question that I want to ask. But I usually tend to say that the US CDC maps are pretty good, even though, with the latest things about the US government, it's still actually fairly accurate, and things don't tend to change that quickly. So I'd still go to the US CDC. And so that's the end, and I have maybe 3 minutes for questions if anyone wants to ask any questions. Oh, there's one on Slido. Is there a new vaccine for dengue fever for travellers called Qdenga, and when will it be available in Australia? So you are right that Qdenga is currently going through the TGA assessment process, and is it just registered? Okay. Oh, it just got registered last week, so there you go. Very, very up-to-date information. So now the next step depends on the pharmaceutical company, the when will it be available. So when will the pharmaceutical company then decide to bring the vaccine onto private market in Australia? And it's something that we'll have to coordinate closely with them through NCS, because we want to make sure that there is guidance in the handbook before the first vaccines arrive. We do have a team at NCS who's working frantically on that. So the next step depends on the pharma company, so I can't really give you a date. Any other questions? Nope. All right. Well, I have given you 1 minute for your next.
Another round of applause for Annie. That was very comprehensive. Amazing. Feel much better now about my influenza boost. Thank you. Okay, let's welcome back now to the lectern Archana for her final presentation of the day, which is handbook highlights, key changes and updates. Over to you.
Thank you. And thanks, Annie, for coming this year. At the Kids Hospital Westmead and at Westmead Hospital, we call the month of February typhoid season. It's a typhoid month because that's the time when all the families come back and our literally our incidence of typhoid exponentially increases. So that's typhoid month. And as an infectious disease physician, really don't really underestimate sex tourism. We've had so many people in hospital because they've gotten this and that, and I had a patient in Bali and this, and then we treated him for a various number of things, and then he was just organising his next holiday whilst in hospital. So it is a big thing, and people don't feel very uncomfortable talking about it. Yeah. Okay, all right, so now I'm going to talk about the Australian Immunisation Handbook latest update, a little bit more dry than sex tourism and typhoid. All right, cool. All right, well, the really, you can all go to sleep after you hear this one slide, just check the handbook. And on the handbook webpage, there's always a list of updates as well, just in the front, on the landing page. And that's always really, really useful. There is the handbook now comes in a beautiful app, and you can actually navigate it a lot better than it used to. And this slide just shows lots of updates. A lot of them I've talked to you about. August 25, we had pneumococcal. December 25, things about COVID. We removed the old boosters. 19 January, we added guidance on RSV and the risk of the very, very rare risk of GBS. 19th January as well, there was an expansion of groups to the MPOX eligibility. 27th of February, more RSV updates, in particular to say every pregnancy. On the 13th of March, flu and the flu ad reg dates. And then May, RSV. And, that was other things. Oh, there are minor updates as well, which you can read. Thank you. All right. Now, I just wanted to flag with you some of the resources I find really useful. So the NCER's Measles Frequently Asked Questions. It's a great resource to look at, because measles is changing every day. And we know, as Annie pointed out, it's a global outbreak. It's not specific to countries. The NCER's measles vaccination clinical decision support tool has been updated. I don't know if you've seen the old one. There was like lots of things that went everywhere, and now it's quite much more simplified. And it talks about people who were born before 1966. Don't worry about them. They may be at higher risk of yellow fever vaccine APHIS, but they're protected against measles. And then if they're born before, it really depends on how many doses they've had. But really, we want everyone to have how many doses in their life of measles vaccine? 2, yes, good. 2, and 2 with the first dose being at 12 months and over, right? Because babies can get it from 6 months, and like Annie said, recommended, I would say it's a must. I've seen, I'm doing another talk to GPs next week about a measles outbreak around Nepean, and we've had a number of patients who've had measles. Okay. There have also been updates to the vaccine intervals and how they describe it in the handbook. Okay, because before it used to be some of the chapters had days, some of them had weeks, and some of them had months. And so if the interval is less than a week, it is now expressed in days. If it's less than 6 months, it's expressed in weeks. If it's over 6 months, it's months or years. And if it's a month, in case of vaccine intervals, if it's just a month, they will talk about it as 4 weeks. Okay, so that's been updated throughout the handbook, so it's consistent. There's been some great additions, infographics, figures and tables, and you can see that there's this one on vaccination for international travellers, vaccination for Torres Strait Islander children, and it's a great, I would just print it out, keep it in your practice. It's also really great for your own self to reflect, but also, most of you are probably nurses, to nudge the GP, and also to potentially give to consumers. We've got beautiful new figures on where to vaccinate, really thinking about that deltoid muscle, thinking about the upper leg, and how to optimise and minimise vaccine errors. There are also some immunisation, medical risk conditions. I haven't looked at this. Do you find that quite useful, Lauren?
Well, it was a new one when the immunisation chapter got released.
Oh, yeah. Yeah, did everyone get that? It was updated when the immunocompromised chapter was updated, and provides a bit of a helpful clue in terms of what medical risk condition the person has and what vaccines may they be recommended and or funded for. I find that quite useful, actually. Okay. So it's just about visiting the AIH landing page, subscribe to receive updates, and subscribe to the NCER's weekly jab. Who gets the NCER's weekly jab? A quarter. I think more of you can get the NCERS weekly jab. I read it too, and I work at NCERS, and I learned so much. I was like, oh. Actually, you know what used to happen? I used to ask the people who prepared the jab, and I'd be like, oh, I've heard about this. Oh, can you tell me a little bit more about it? And they're like, it was in last week's jab. And I was like, oh, sorry. So I've started reading it too. Okay. Sorry? There's a QR code at the back, yeah. So I want everyone to take a photo of that and then be a subscriber. And I'll get like a good pat on the back from my NCERS communication team. Okay. And then I'm just going to talk about other updates, okay? Because we've talked about the handbook and the handbook updates, and everyone's a bit tired, so let's talk about what else is happening, right? So this is Finding Pneumo. So we're running this clinical trial, and it's an observational trial by a colleague of mine, Rama Kandasamy, and it's looking at causes of pneumonia in kids, looking at which serotype. You know, I talk to you about serotype. So now we have all these new vaccines that cover more serotypes. We really want to know the lay of the land. Okay, so that's just started, and I created that pig and with the little pneumococcal as Dory. I thought that was pretty cool. Yeah, I sent it back to Rama saying, "Oh, I've created this. You could use it." Anyway, so it's enrolling now. We've enrolled like 3 or 4 kids, I think, from the kids' hospital. And then Annie talked about the intradermal versus a subcutaneous trial, and it was. It was looking at seroconversion at 1 month post-immunisation. And it showed that in 5 to 18-year-olds, 100% seroconverted. So that's cool, you know. It shows that if needed, we can give the intradermal vaccine. And if you were older than 50, you seroconverted 95%, and if via intradermal, and 99% via subcutaneous. So that was pretty much on par, like very similar. So it is a great study that, like Annie said, it was conducted in Western New South Wales. Okay. And then there are other miscellaneous things that you might kind of ponder about and want to know about. Do you remember who was here 2 years ago? I think Nick talked about the patch vaccines. Yeah. And so we were saying, what happened to the patch, hey? Well, there's been really good overseas studies in the continent of Africa around the measles immunogenicity, and it showed an IM vaccine was equivalent to this patch, and the patch really didn't require a cold chain. It really minimised the use of cold chain. And so that was really good. And so now this is an Australian company, Vaxis, based in Queensland. They've been granted approval to manufacture this needle-free, and hopefully we'll be able to utilise regular vaccines in it and see where that goes. So that's super news. The other thing is that there are lots of vaccines on the pipeline, and unfortunately, there was a mRNA vaccine that was looking at prevention of congenital CMV. CMV is a herpes-like virus, and it can cause severe disease if acquired in pregnancy to the fetus. But they've scrapped it because it didn't show that it really made any difference in a phase 3 trial. And then we talked about H5 avian flu. I think I mentioned it last year about avian flu. It's still an epidemic. It's still a big problem amongst animals. Very few infections in humans. But there's an amazing trial that's being put out by the Department of Agriculture on vaccination of priority native birds, just to make sure that we protect them from elimination. Yeah, so that's kind of cool. Annie talked about diphtheria, so it is a problem, and we're getting really sporadic outbreaks in the last, 5 years, and there's been a not insignificant outbreak amongst the northern parts of Australia, mainly in NT. Fortunately, the cases have been very mild, so that's really good. But the cases have been primarily the skin infections, and the skin infections are much lower risk of disseminating into into heart problems or nerve problems that can cause complications. But there have been a couple of cases where it's been isolated in the throat and even mild pseudomembrane development. So it's really frustrating, but when you have declining immunisations in pockets and then you have other factors like the bacteria itself, and the toxin itself, that you do get resurgence of old diseases. But vaccines work, and I'm preaching to the choir, but since the start of the diphtheria vaccines, we have pretty much almost eliminated diphtheria. So, okay. So some updates in social science research. So we asked parents who had partially vaccinated their kids versus parents of kids who kids were up to date in terms of why or what belief they had around vaccines, or were there any barriers to vaccines. And you can see in 2025, so this is an odds, so the difference between the two groups, right? And in 2025, more people who had their kids partially vaccinated compared to 2024 didn't believe that vaccines were safe. Yeah? The 2025 questionnaire was asked during September, October, when there was a lot of media attention around RFK Jr.'s kind of policies around immunisations, and that may have had an influence. But that is worrying to know that there is that more people. So people who have partially vaccinated kids are more worried that vaccines are unsafe, but that worry has actually increased, over the last year. The number two was that there was an increased mistrust in vaccines from a doctor or nurse, and that people just didn't prioritise the appointments. And then I just wanted to kind of also highlight that, don't believe vaccines are effective, doctor, nurse cannot answer questions, and people close to them don't support vaccination. And you can see down below, the barriers in terms of physical barriers haven't really changed, that they can't get to an appointment, not easy to travel. Those are all important barriers, but they haven't kind of increased over the last year. It's been mainly the acceptance barriers. So we worry about people having negative beliefs about vaccines, lack of trust, and choosing not to prioritise. And then this is unvaccinated versus up-to-date, and it's a similar trend where more people who have kids who are fully unvaccinated or don't believe that vaccines are safe, don't protect others, and have a mistrust in the healthcare system. All right, so kind of there were those problems, and then what we also did in NCERS, not myself, but the social science group, they looked at the flu vaccine in particular in children in terms of what helps and what gets in the way, and this was a New South Wales-driven qualitative study, and this was before the implementation of FluMist or LAIV. They surveyed parents aged 1 to 4 years, and this was in October to November, and did online interviews. And you can see it's probably a little bit small in terms of its projection, but things that made people want to vaccinate their kids was that there was a belief in protection, there was a trust in safety, there was an emotional motivation. So if they knew a child who was quite sick with flu in the past, and they wanted to avoid that to be repeated, and also role modelling, so parents who vaccinate themselves. Barriers, again, similar barriers to the NIP vaccines that I mentioned. There were doubts about effectiveness, safety concerns. There was this huge perception of low risk, that flu is just like a common cold. And in the lay language, and you experience this, a lot of people find that flu is synonymous with common cold. Don't you reckon? Yeah. And then needle distress, social influences, and then access and practical facilitators are opportunistic offers. So if you see a family for any other reason, you offer them the vaccine, they're then and there, and they tend to accept it more. If it's a strong recommendation, if we keep just harping on about it and talk to them, but also one of the things that was found to be useful is just listening, because a lot of parents feel very uncomfortable broaching vaccines when they have a concern, right? Because they feel like they will be judged. So just listening and just coming with a common understanding that you and them are both there to protect that child or them, right? And so acknowledging that as a parent, they are looking for the best welfare for their child, and you are trying to facilitate that too, right? And then, and then having reminder gaps seems to be a barrier as well. Where am I? Okay. So some of the other things I found really interesting was that parents liked that the flu mist didn't involve needles, and they said, yeah, I'd probably give that to my child, but it needs to be convenient, accessible, and I need to get some really good information, right? And so what parents said that healthcare people should say is that it's a painless spray to the nose, and it is painless. I've tried it on myself. AstraZeneca came around, it was just saline, but I tried it myself and you can't really feel it. So it was quite painless. So they said to use that phrase and to support parents, obviously, with timely information. So, and parents wanted information both about the vaccine, but also peer experiences. And that's really hard for us to do, but perhaps just talking about it with your non-healthcare associated family members, talking about it with, generally in conversation, it might be something to consider. The other thing I mentioned was the Sky website, and a lot of the Sky website is aimed at lay or members of the public, trying not to really shine a kind of a healthcare preaching type lens to it. And people did want governmental website info. They wanted also info from other places, such as social media. And really having vaccine champions or people saying, yeah, I've immunised my child with that, and that's what happened, and this is what happened. So stories tend to work well with family. So thank you so much, and I leave you. I was very blessed to be here during World Immunisation Week and for Every Generation Vaccines work. And I always like to show a picture of Professor Nick Wood, and he also, I think, was it self-administered a mock LAIV vaccine? Yeah, and he's smiling, right? Yeah. And at NCERS, we also have a little stall today, inauguration, and that's Dee, who was here last year, and Kath, one of our amazing she works for the safety team, and they made cookies. So Annie and I were looking at the photos, and there are some that are measles, there are some that are meningococcal, there's some that are fulminant pneumococcal sepsis, right? And there's a vaccine there too. And we're always around to help. We're always just an email or a phone call away, and always a pleasure. Thanks.
There's the QR code. Thanks, Arch. And of course, always a pleasure. Breath of fresh air having you with us. Thank you. Right now, it's a quick-fire Q&A session. So if you've been submitting questions to the Slido, we're now going to bring up Belinda Tracy, Manager Immunisation and Communicable Diseases team at the PHU, to facilitate the quick-fire Q&A session, along with a big welcome back in some form, a wonderful panel of speakers. You can stay seated, speakers. I don't think you need to, unless you want to come up and stand up. And we do have hands up PHN staff with roaming microphones, so please put your hand up if you do want to ask a question, and wait for the lovely team members to hand a mic before you talk. So we'll get through as many questions as possible. Yep. I think we're doing well for time. So over to you, Bill.
Thank you. Hello, Orange. Yes, I hope you've enjoyed the day so far. I lent the microphone to wonderful speakers today, so you just get me for the Q&A, and we'll make it short, sharp, because we're not finished for the day. We've still got Kendall coming up this afternoon, so hang in there. But hands up, who's got a question off the floor? Oh, we've got one already. Thank you.
Hi, I've just got a question about the flu mist. There's been some concerns with the porcine in it. Are we supposed to disclose that? Is it an issue?
Archna's coming, hang on.
Yeah. There's been a lot of discussion around that. And there's so it's porcine gelatin. There's actually porcine gelatin in one of the MMR vaccines too. And generally, we traditionally haven't gone into all the details of every vaccine constituent. So we had a chat at NSWIS, and we feel that you need to discuss this vaccine as you would with any other, to the same standard you would as any other vaccines, right? So it's really in terms of your constituents, if you have a lot of people that have been concerned about some of the MMR vaccines that contain it, or if it's something that you discuss, then just keep doing that. Otherwise, I probably wouldn't. There is good information on the website about it. There's also information because, again, this is not new, right? Some vaccines contain beef gelatin, sometimes contains porcine gelatin, right? It's just that there has been, an imam that has said, it's sort of highly hydrolyzed, and I endorse it. There's also been rabbis that have endorsed it, but of course it's to the patient's preference, and it's usually an issue in the Orthodox Jewish and Islamic communities, but also in vegan communities. So my take is, I probably wouldn't discuss it if I haven't discussed it with other vaccines. Yeah. What are your thoughts? Anyone else? That's what we need. Oh yeah. And the other thing is that you can, if there is some concern, the jab doesn't contain gelatin, so the IIV is a good alternative. Yeah. It's a difficult question because you want to make sure that you are fully forthcoming with your community as well. So I guess it's nuanced depending on where you work. Yeah. It's hard. Yeah.
Do you want to answer this question?
Oh, okay. Yeah.
It was just about the multiple administrations.
Oh, that's beautiful. She's got some beautiful photos of her kids on the thing. Where is it?
As an immuniser who will likely administer many flu mist vaccinations, am I at exposure risk to too much aerosol vaccine?
Oh yeah, no. It's actually, whoever can give that question, if you've seen it, it's actually quite a small, an extremely small dose. And I was surprised because I thought, oh, Nasonex, all this. It's so small, and there's really hardly, it can't even really spray out. The only risk is that some kids will sneeze, right? But no, but as an immunisation provider, you should be up to date with your flu vaccine anyway, so. And, yeah.
Exactly.
But no, I was pretty impressed.
Are there any more questions off the floor? Can we have a microphone here? And while the microphone goes, how many doses of influenza can you have whilst pregnant?
All right, yeah. Well, probably, you probably have one. The reason why I had two there is that some people might be going, if you had a flu vaccine really early or just before pregnancy, and you lived in an area where it was the flu was more in a temperate region, then you could still have that second dose. But I wouldn't give more than that additional second dose if just pre-flu season.
Yeah. Your question?
With the self-administration for now, you can test for influenza A, influenza B, RSV, and COVID. So you guys or whoever is missing out on all that data. Should there be an easier way for people to self?
Oh,
self-notify?
self-report.
Yes.
Yeah, it's a bit messy, I guess. Like in terms of now, it's just easier to get the data from a lab, and with COVID, it's usually people that are hospitalised that will have the PCR testing. Yeah, you may maybe just say that there are odd
so
studies.
I was just going to mention that there is Flu Tracker, which is like a self-reported kind of, so not everyone participates, and it's more symptomatic. So I guess we do get flu information from a range of places, and we still get a good sense of what's happening in the flu world.
Yeah, that's right. So we always knew that we underestimate the notifications, and that's how it is. And it's really looking at trends compared to years before. Yeah, it's a good question.
Are there any more questions off the floor? I've got a few on Slido. Okay. We're going to pick on who?
Oh, yeah, can I sit down?
We've answered the question about dengue fever.
Maybe I'll answer that GBS one. Oh, okay, can I talk here?
So if someone has had GBS, can you still give a Rexv?
Yeah, so when you say GBS, so it's Guillain-Barré syndrome, really what I would do is you'd have to take a very close history. So a lot of the times the Guillain-Barré is not associated with any vaccine product. Things like Campylobacteria diarrhea can precipitate it, and lots of other things can precipitate it. It's a very non-specific kind of illness with lots of different triggers. And so on our website, we have a flow chart in particular for flu, and to say, yeah, if you've had Guillain-Barré syndrome that was approximate to the flu vaccine, just have a think about, was there any other trigger? How likely do you think the vaccine might have contributed, and then what was contained within the vaccine? Whether it's similar things that might have been contained within the vaccine is in the other vaccine, but a lot of the times it was nothing to do with the specific vaccine, and you can get immunised.
I think the question was if they had previous GBS, not in the context of a Rexv, can they now get a Rexv?
Yeah, they usually can. Yeah. But you really do need to take a history in terms of what triggered that GBS. Because Rexv is an adjuvanted vaccine. It contains the same adjuvant as Shingrix, is that right? Similar, yeah.
Okay, any more questions from the floor? No? All right, here's another one. Are there any plans to add Prevnar 20 at 6 months as a drop-down box option on air for Aboriginal Torres Strait Islander children, given its 4-dose schedule?
Where's Wendy gone? I did actually ask the air team that question when I saw it, and it is actually there. You've just got to scroll down and add another vaccine, and it is in the drop-down box. So you just got to look, add another vaccine. So it is there. So you just need to look. Yeah.
Yes. Update your practice software is Annie's hot tip. Okay, Kim and Fiona. If a child has 3 doses of Bexzero vaccine at 6 weeks, 4 months and 6 months, do they still need another dose at 12 months, or are these 3 doses a complete course?
Well, what is everyone thinking? I'm thinking yes, like you should have a booster at 1. Archana, would you say the same thing? They've had Bexzero at 6 weeks, 4 months and 6 months for some reason. I don't know why. I would suggest a booster then at 12 months.
Okay, we're getting restless. This is good. Okay, it's 3:30. What's our time frame? Is that 10 minutes done? No? Okay, beautiful. Any other burning questions from the floor? No? Beautiful. There is a lot of media hype on the adverse effects of COVID vaccination. Who wants to discuss this? There is a lot of media hype on the adverse effects of COVID vaccination. Do we want to explore that?
Whoever put that question up, can you elaborate? You know, there's been just media hype around vaccinations, really. I think unfortunately the pandemic required the globe to be vaccinated, and then everyone realised that they needed to be vaccinated, and it was just mixed in with negative emotions about the pandemic, about isolation, about mandatory vaccination, about government telling you what to do, So I think it's all kind of mixed in. In terms of there's some myths about the COVID vaccine because it's an mRNA vaccine that it travels all the way around your body and enters your brain. Really, mRNA is so fragile that it can't travel anywhere. It enters the cell, it produces the protein, and it breaks down. So yeah, if you've kept your mRNA vaccine outside, if you keep it outside, it pretty much deteriorates after a number of hours. So yeah, it's tricky. Yeah.
Lots and lots of tricky questions when it comes to COVID. Dr. Carey, there's a question just for you. What is the time frame from the bite of a bat to the patient for vaccine to be dosed?
The advice is you give it whatever the time. I mean, the sooner the better, but you never withhold. You go, oh, it's been too long. You give it. The key thing is there's a time frame for giving rabies immunoglobulin, and you've got to give that within, I think it's 7 days of the dose, the first vaccine dose. But you can give the course at any time, but the sooner the better.
Thank you. Any questions from the floor? No. There's one more in Slido that I will ask. Is Fluad approved for Aboriginal people over 50? And did you do some research on that, or who wants to answer that question?
Yeah, it's approved for use, but it's not funded. So the Fluad is not funded for anyone on the NIP unless they're 65.
All right. Are we done? Time? So I'd like to thank all the presenters thus far, but don't leave the room. But yeah, one big giant applause for the presenters so far, please. And over to you, Brenton.
Thanks, Belle. In fact, we're going to keep that clapping up. We're going to just do a quick energiser game. So if I get you all to stand up for a second, just give 5 minutes just to entertain us all. Let's just to wake you up for the final session. Sort of attempt to wake you all up before we head to the finishing line. So this is a bit like a Simon Says, if you've all heard about this. So if I say 1, you clap once. If I say 2, you clap twice. Clap, clap. If I say 3, you clap 3 times, right? Pretty straightforward. But there's a twist. It's not that easy. If I can say any number, but you're only to clap on 1, 2 or 3. If you start clapping when I say 5, you sit down, you're out. Okay, now there may or may not be some treats or gifts for those that remain standing. All right, so let's do a quick practice round, all right? You ready? Hands at the ready. Now this is going to go really, I'm going to do it slow to begin with, but then it gets really, really fast, so it gets harder. We're going to make this easy for you at 3:30 of an afternoon, okay? So a quick practice round, you ready? 1, 3, 1, 6. All right. That's our practice round. I think we know we're not doing too well so far. Okay, now the game starts. Are we ready? Okay. Ready, focus. 2, 2, 3, 4. Sit down. 1, 2, 1, 2, 3, 20. Oh, good. 3, 3, 3, 1, 6, 7, 1, 2, 1, 3, 6. Jeez, you got, okay, everyone gets a gift. Right. Sit down now. It's all good. Clearly you are all paying attention, so... Right, so to round out the day, we have our final session. Last but definitely not least, please welcome Kendall Ball. With Houston, we have a problem. Adverse events following immunisation and vaccine administration. The microphone is all yours.
Hello, everybody. So I drew the short straw. So hang in there. We're nearly there. We're nearly there. All right, so I'm going to talk about APHIS and vaccine administration errors today. Now, I know Archana did a bit on APHIS. I'm going to do what happens after you've treated the patient and you know they're fine, and what we're going to do after that. Oh, I need the little button, don't I? So, for those of you... Oh, no, that's not the picture I put on my original... Are my pictures still there? Hopefully my photos are all still on the thing, because they're funny. And there's no name and shame this year. I'm not going to shame anybody. There's no photos from vaccine fridges in the Western area. They were all off the interwebs this year, okay? Ah, there it is. Okay, so what's wrong with this picture? When did we start injecting with a 5ml syringe with more air in it than fluid? Okay. Okay. Right, so learning outcomes. We're going to do vaccine development, vaccine safety and surveillance. We're going to do a bit of a refresher. What's an APHI, what's a vaccine administration error, and what to do when an APHI occurs. What to do when a vaccine administration error occurs, what forms to use and who to call. Okay, this picture came from a very reputable education institution on the splash page of their vaccines in pregnancy educational package. So, what the hell is he doing? So, yes, maybe that's why people have reservations about vaccination. Okay, so quick revision. Vaccines go through phase 1, phase 2, phase 3 and phase 4 trials. Phase 1 trials are preliminary vaccine safety, tested in humans with a very small number of participants. If that goes all well, phase 2 trials, larger cohort of participants relating to the target population of the vaccine and the schedule that's needed. If that's successful, we go on to phase 3 trials on a much larger cohort, testing safety and testing of immunogenicity. After that, they apply for market authorisation. So it gets approved by PBAC, then it goes through the TGA and ATAGI, and then it's distributed. Phase 4 trials start when it's approved. So this can go from 12 to 15 years after the vaccine's approved, and sometimes even longer. We're always monitoring vaccines. So monitoring vaccine safety post-licensure, there's passive and active surveillance. Passive, which is spontaneous surveillance. The TGA collect reports from all of side effects and other safety concerns. Information comes from all levels of healthcare and also the public via reports and surveillance systems. Serious APHIs are investigated by the Vaccine Safety Investigation Group, and it's possible that an APHI may change the benefit-risk profile of the vaccine. So you have to fill out the APHI form. So active surveillance is Vax Tracker. So we've spoken about Vax Tracker today and AusVax Safety. So that's not passive surveillance, that's active. So when you have your flu vaccines through staff health, when your kids have their vaccinations through the school vaccination program, we intentionally send you a survey, or AusVax Safety intentionally sends you a survey, you fill it out, that's active surveillance. Passive surveillance is things like admission to hospital monitoring. So when we get the reports from, flu-like illnesses and stuff like that are identified in all of the coding in hospital admissions, that's passive surveillance. Oh, I hit the red button. Okay, monitoring vaccine safety. So this is AusVac Safety. So you can go onto the website. I'm pretty sure we've all seen this before. If you haven't, go and check out the website. It goes through all of the reported side effects from the vaccines that are surveyed on the website. Okay. Adverse event following immunisation. So the Australian Immunisation Handbook is any negative reaction that follows a vaccination. It does not necessarily have to have a causal relationship with the vaccine. And it may be caused by the vaccine or may have occurred by chance. Okay, another photo for you. Like one-handed and into the elbow. So it's, you know, I showed photos of deltoids last year. They weren't there. Okay, so APHIS can be minor or severe. Minor is a sore arm, localised redness, lump at the site, short-term malaise, mostly the normal side effects that you wouldn't report. The major ones are Guillain-Barré syndrome, seizures, pericarditis, that sort of thing. Anaphylaxis, obviously. Range from severe but are rare. Anaphylaxis, Guillain-Barré, febrile convulsions, interception with Rotarix, and we went through most of that. Hang on, if I go back, I'll keep forgetting. I don't know whether they're injecting steroid into the joint or not, but that's frozen shoulder. Okay, that one. I love that. They all look so happy. They look, I don't know what they're giving, but they look so happy. It must have been really good. It was rubella, yeah? It's reusable, I love it. Okay, reporting on APHIS. So when you're reporting an APHI, don't panic. After you've treated the patient, don't panic. Inform the person being vaccinated about the possible adverse events. So they should know that it's a possibility before you give them the vaccine. They should know that there is a possibility that there can be side effects. They're very rare, but they can happen. Common and minor side effects that are expected side effects from the vaccine should be a part of informed consent. Report if there's any serious or prolonged adverse events. We'll get the experts to decide if this is a result of vaccination or if it was a coincidence. If you're unsure if the reaction requires reporting, give us a call. That's scarification for measles, smallpox, sorry, back in the day on a poor little baby. Okay, so future vaccination after previous APHI depends on many things, including this type of APHI, the severity of the APHI and the vaccine that was used. Most people will be able to receive vaccines after some investigation. May need a comprehensive assessment and advice from a specialist immunisation service such as NSWIS prior to future vaccinations. This is the one we all get a bit caught up on and we all get a bit of a panic about. So vaccine administration errors. I can't count how many times I've had phone calls, probably from some people in this room going, oh my God, I just got the wrong vaccine. Oh my God, what's going to happen? It's fine. They'll be okay. But we are our own worst self-critics. So vaccine administration errors can occur as a result of errors in vaccine preparation, handling, storage or administration, poor storage or administration, and can be associated with immunisation error-related reactions. Immunisation providers' responsibility to manage and seek advice from the doctor and PHU straight after the event. So if you notice straight away that you have made a boo-boo, give us a call. If you notice 2 weeks later, give us a call. It's never too late to report it. Reporting vaccine administration errors is also another form of passive surveillance. So if you, for example, give a flu miss to an 18-month-old child. There has been studies done on that and the side effects of that. But it's also part of the post-marketing surveillance. So if it's the stuff that we can't test. So, no, it shouldn't have happened, and no, you have to go through your rigmarole and your IMS or your reporting at your own local level. But if you report it, it gives us data, it gives the TGA data. For those Category C medications, don't give in pregnancy, it gives us data. So don't be afraid to report it. When we say we need to fill out a form and send it to the TGA, it's not because the TGA needs to know your name, it's because they need data. Okay. Forearms, really? Okay. Just so you know, we don't vaccinate babies like that. Okay, common errors. So some common errors are giving it an out-of-date vaccine. That's pretty common. Making the Abrysvo, Arexvy, Beyfortus errors. It's a confusing space, the RSV space. Hopefully everybody's getting the hang of it now. But giving the wrong vaccine dose for the age in the Quadricell, Adacell, Boostrix. They all have age caps on them. The wrong vaccine for the job, so giving paid doses when you should have given an adult dose, the incorrect pneumococcal dose, minimum time frame between vaccines not met, which is going to require having to give another vaccine, too many doses of a vaccine being given because you didn't check the AIR, vaccine diluent given without reconstituting. I think that's pretty common. We've all done that. I've done that. The wrong route of administration, and storage errors, so, not reporting cold chain breaches, etc., etc. We'll lose a bit of sleep about it when we make a vaccine administration error. There's a couple of people in the room who will attest to the fact that I picked up a Hep B vaccine when I was supposed to be giving a pneumococcal, and my colleague was giving a Hep B vaccine, and she came over to the bench and went, "Where'd my Hep B vaccine go?" Oh, no, just went in her arm. And now I've got to go explain her. Luckily for me, she was a very accepting lady, and she said, "Oh, my husband keeps telling me I need to have that. I probably should have the other ones now, shouldn't I?" Yeah, well, thank you. Okay, so be open and transparent. As soon as you recognise it, ring the patient first. Don't ring the patient before. Don't ring us first. Ring the patient first and tell them, once you've got straight in your head what the side effects might be, what you need to keep an eye out for, ring the patient and tell them. If they're still in front of you, even better. If you try and cover it up, that's where you come into vaccine hesitancy, and people don't trust us if you're not open and honest. Full disclosure as soon as possible. Call us after that. So if the person's not had a reaction to the vaccine, they've not had an APHE, not had an allergic reaction, they've been seen by a doctor at the practice or wherever you are, then give us a call. And monitor for any side effects, and make sure that the family or carer know what sort of side effects to look after, and follow up with a phone call the next day. That goes a long way. Okay. That's the form. So when you ring the PHU, we'll say fill out an adverse event form. That's also a vaccine error, administration error form. It doubles up for both. All right. Reporting APHEs assists in finding rare or unexpected side effects from vaccine that may not have been identified in clinical trials. There's always random things that happen. Identifying problems with manufacture, storage, delivery or administration of vaccines, monitoring side effect trends in specific population, and reporting VAEs, it assists in investigating and identifying the cause of the mistake. So maybe, for example, oh, hang on. No, I think it's a few slides away. We'll have a look at it then. What actions you need to do to resolve the situation, prevent similar errors with safer vaccine practices. All right, so I've got a couple of case studies. So we had an AFI in a 74-year-old female with minimal health issues. She had a Prevnar 13 on the 29th of the 1st, 25, and she had a Shingrix on the 5th of the 2nd. On the 9th of the 2nd, she developed numbness in the soles of her feet and fingers, progressing to glove-like numbness and stocking-like numbness. She attended the GP on the 9th, 10th, 16th and 19th of February before being admitted to hospital on the 19th of the 2nd. She was discharged on the 18th of the 3rd and had outpatient rehab until the 16th of the 4th after being diagnosed with Guillain-Barré syndrome. The AFI was not reported to the PHU until May 2025. So out of all of those health professionals that she went and saw, and it was documented in her notes back at the start of February, low suspicion for GBS. So, yeah, and then, but nobody in that whole process realised that we needed to know about that. Yeah, so we hadn't heard about that one. She's fine and well now and lovely. The next one is a vaccine administration error. So we had a 6-month-old healthy baby, fully vaccinated for age. Father requested a RSV vaccination for a child at the 6 months vaccinations. A Brisvo was given instead of Beyfortus. Beyfortus is a long-acting monoclonal antibody, not for adults. B is for baby, Beyfortus. So trying to come up with little things locally. And I know that the NCS and the New South Wales government have also put out stuff to try and sort of overcome the similarity in names of the vaccine and the monoclonal antibody. No RSV vaccines are licensed for use in children. Well, they weren't at the time of writing the presentation. No, good. No, good. Cool. So, but that's not the first time that's happened, and it probably won't be the last time, and it happened. And from all of those mistakes, so your mistakes and your reporting your mistakes can actually inform our future practice. So from that, safety notices were sent out, well, not from that case, but from those mistakes and people reporting them, it can inform future practice. So, I wonder, this is my little thing, I wonder whether next year that flu ad won't have 450 and over on one side and funded for 65 and over on the other side. I wonder whether or not this year might change the packaging for next year, but little things like that. So when you're reporting, you're actually helping us. Okay, in summary, regularly review guidelines and policies to prevent mistakes at a local level in your practice. Never ignore something that could be a severe AFI. Always contact us if you're not sure. We're happy to take the phone calls and reassure you or say, yeah, no, this is it. Always follow all of the available policies, the Strive for 5, the Immunisation Handbook, all of those things that are available to you. Always use the Australian Immunisation Register. It's really hard when things haven't been recorded and somebody else goes to vaccinate later on, and it will prevent vaccine administration errors as well. Use your co-workers. Usually when you start somewhere, there's a couple of people there who know everything about vaccination. I had a couple of them myself when I first started vaccinating. So use them, always talk to them. Vaccination, getting your head around it's really hard. And if in doubt, leave the vaccine out until you get some advice. And that's it.
Thank you so much, Kendall. Could almost be a jingle. If in doubt, leave the vaccine out. Right. As we begin to wrap up, just before we do, really appreciate a few moments of your time to complete the evaluation survey. So please scan the SurveyMonkey QR code on the program. So, of course, your feedback goes a long way. Helps to reflect on today's forum, Shape Future. We've already had a couple of verbal feedbacks earlier, which has been fantastic. So please pop on. I'd love to hear your thoughts and for some continuous improvement as we continue this great conference year after year. And while you're doing that, we now move to some prize draws, all right? So definitely ending on a high note. And Belinda's going to come and do the honours while I hold the raffle box. And
I think we're going to do something else first.
oh, are you? Oh, the years of service, yes, over to you. Yes.
So something a little bit different this year. The PHN have done a bit of a scour of some wonderful nurses in our district, and they've done a bit of a count of how many years they've been practicing their immunisation and nursing career. So thank you, PHN, for going through the names and collecting some information. So hopefully Alana Benson is still in the room. Yes, I can see her. So only 33 years of experience has been acknowledged. So come up here, Alana. It's just a small thank you from the PHN. Yes, they've all grown up. Congratulations and thank you. Do you want to tell a story or? Tell a story? No? Other than, yes, the story that you told to...
Everybody out there that knows me say don't get us started.
Now, another person was acknowledged with 33 years, but I've only been given a Christian name. So if there's a Denise in the room who's been practicing... Denise Hopkins. I've joined the dots for you, Michelle. So congratulations. And just pop over to Erica. Well, that's very, very good. Thank you very much. And I know there's some other nurses in the room that have been slogging it out, and I think the Slido earlier in the day definitely demonstrated how many nurses we've got in here with decades of experience. So a huge nod to you all for being here and your years of service. And don't go away, because I think, we need lots and lots of nurse immunisers. And talking about that, if you've got a friend or a foe that wants to become a nurse immuniser that works beside you, please send them to the PHN or to the PHU so we can encourage them to get their certificate and join this workforce and become vaccinators. So we've got to recruit, we've got to grow our own. So let's get those nurses into this space. All right, so next up is the Lucky Door Prize, I think.
3 prizes, yes.
3 prizes. I think I'm doing this bit. So I hope you've got your tickets on the ready. We have blue, A47. Have we got a winner? Oh, yes, we do. Come on up. Okie dokie. Number 2 is a green ticket, C81. Are you still here? Yes, welcome. Come on up.
Lucky last.
It's another green ticket. It's C84. Oh, come on up. Well done. Thank you for all still being here at the end of the day. Okay. There you go. All right, so we started off the day with a bit of bingo on the tables as well. So some wonderful people in the background have been collecting the bingo cards. So we've got the 3 winners. So we've got Rachel. Where's Rachel? They didn't put their surname on here.
So anyway,
Maybe.
you can come up if they like. You will have to talk about
the name on the back. What's that?
That's the name of the person who submitted the form, yes.
Rachel?
Yep.
Christine Thompson. We really should talk about how this rolls. And another winner was Ange Thornhill. Now, do you want to tell a story about your persons? And Tanya Maslin.
Any unique insight?
Come on. Here's your ticket, look. You can talk about immunisation.
Oh, okay.
You can talk about anything.
I'll just share an early experience I had in Bathurst. In the 90s, I was immunising. I was working at the health centre as a primary healthcare nurse, which that funding doesn't exist anymore in that same way, but we used to do health promotion in the shopping centres, and when we did vaccination clinics, the council brought the vaccines, and we just turned up and they did everything. They had done the appointments, and so I think it's come a long way and given it back to nurses, which it needs to be.
Beautiful. Thank you.
Fantastic.
Where are we up to, Brenton? I think
That's it. Prizes
that's
are done.
you.
That's me.
Close this show.
Thank you so much. Thank you, Belle. And congratulations to all the winners and to everyone here today for making this such a fantastic event for another year. So travel home safely and hope to see you next year. Thank you.